A very good evening. Welcome to this IRSI webinar on laser cataract surgery. And tonight we have a very exciting lineup of some of the best surgeons from India and abroad. And we are lucky to have the stalwarts who have been always the leaders in cataract surgery. And today's webinar is not about why we should be doing Femto or why Femto is better than Phaco or Phaco is better than SICS. It's just about how many of us have adopted laser cataract surgery into their practices over the last few years and are getting the best out of our various techniques. I'm sure all of us are doing almost all the techniques there are to offer for cataract surgery, and how we utilize laser cataract surgery to its fullest potential to get good outcomes for our patients. I would like to introduce, we will be joined by my co-moderator, Dr. Mahipal Sajdev, a little later. I would like to introduce today's panel and speakers. So this is our lineup for today. It's the A-team lineup. So it's my pleasure to introduce myself, and Dr. Mahipal would be helping take this program through. We have a renowned panel of panelists. We have Professor Chi Soon Fake from Singapore. She's no stranger to the Indian, Indian ophthalmology forums. She's one of the pioneers of laser cataract surgery, has delivered an oration at the APSCRS. In fact, I was lucky enough to attend that beautiful oration where she lined up how she finds femtocataract surgery, to be one of the better techniques for some of the situations. We have another pioneer of laser cataract surgery who has been doing it for the last 5-6 years, Dr. D. Ramamurthy. Again, no stranger to our viewers here. He's been the past president of IIRSI and from Coimbatore, the chairman of the Eye Foundation. Our third panelist for today is Dr. SPS Grewal, and I'm happy to share with you that before I started doing Femto about 5-6 years back, I visited his clinic to pick up some of the pearls that I learned before I started doing Femto. Again, a prolific surgeon and a perfectionist. We have with us Dr. Rohit Omprakash from Amritsar, again one of the leading surgeons of North India, India abroad, and of the IRSI. And he organizes amazing meetings in Amritsar every year in January, like this year. He again is very experienced with the two different laser platforms, and we will be using his wisdom to understand how we can use this better and where we can. He's again a big proponent of Phaco, so we have him on panel here to tell us where he would prefer to use Femto and where he would still want to do Phaco, and that will be nice to hear both points of view from Dr. Rohit sir. And we have another stalwart, Dr. Sharad Babu, who's again been a senior AIOS member. He's been past member of the IIRSI and the scientific committee, and is a prolific surgeon. Has been doing femtocataract for about a year or so, and has lots of experience with in this short period, has done a lot of work. We have a lineup of tremendous speakers. I will introduce them as they come. And I'm going to start off today's session by inviting our first speaker, none other than Dr. Partha Biswas. Now, again, he's one gentleman in Indian ophthalmology who needs no introduction. He is the chairman scientific committee of the AIOS. He has done tremendous work as the chairman of ARC of AIOS over the last 6 years. He set standards for what all can be achieved during his tenure. Again, has a great temperament and is a brilliant surgeon from Calcutta, from the BBI Foundation. I'll invite Dr. Partha to share with us on where we are today with laser cataract surgery. Partha, would you like to welcome and go ahead, tell us where we stand?
Thank you very much, Gaurav. I'll just share my screen. I'm really grateful to Gaurav and the whole team of IIRSI for giving me this opportunity to be here with you today at laser cataract surgery, when and why it scores over Phaco. So all of us have graduated from ICC to ECC and to Phaco, and now we have the Femto. So why, how, and when? And look at these two poached eggs. Which one would you like to have? Of course, the one with the rounded borders, the one that is aesthetically beautiful, the one on your right. And right is your first choice. The advent of femtosecond laser ophthalmology was in 2001, and a paradigm shift in the field of refractive cataract surgery and its high precision and safety was what revolutionized cataract surgery. And then we have come to this era of refractive cataract surgery. But can it replace phacoemulsification? And possibly the same question was asked when Phaco came into the modus operandi and in the forefront years ago. And then people asked, can Phaco be the standard of care over ECCE IOL? So we had the answer, and this today is the answer. So the era of refractive cataract surgery is here, and it has come to stay. Flax versus Phaco, and the debate will continue. But look at an automation of the surgical steps. Are there real benefits for the patient? And the costs, which is killing, does it really justify the cost? So over this time that we are going to be here in this webinar, I think all these questions would be answered by our speakers and our panelists. So now where cost remains a limiting factor and Flax has proven its worth in the last decade, it makes routine surgery easier and safer. So if I have to ask this question to myself and to my conscience, would I love to do Phaco or Flax to every cataract surgery? My answer would be Flax. Of course, not assuming the cost factor. It makes the challenging cases better, and the challenging cases are definitely worth importance because each challenging case requires the best. And these selected cases, it has actually become the procedure of choice. So a perfect, pristine capsular opening is a prerequisite for every cataract surgery and every cataract surgery which has a premium intraocular lens. Now let us look at this posterior polar cataracts. And Dr. Vasavada and group came up with this beautiful article in which they said that the Phaco delineation was a technique that could actually give safety to the posterior polar cataracts. And this has a great importance. Let us look at blunt traumas and cataracts arising out of blunt traumas, the traumatic cataracts with penetrating and blunt injuries also can be amenable to Flax. Phacomorphic glaucoma, another difficult situation, and Flax is definitely at the lead in such cases. So if we all ask ourselves, even after 20 years of phacoemulsification, my rhexis does run out. Even after 20 years of phacoemulsification with an intumescent cataract, and even doing a cataract and all the evaluation, I have an Argentinian Flax sign. Even after 20 years of phacoemulsification, at times my wound leaks. And even after 20 years of phacoemulsification, my hard cataracts definitely requires a lot of patience, a lot of ingenious maneuvers, parameters, all have to be modulated. Even after 20 years of phacoemulsifications, subluxated cataracts are still a difficult situation. And even after 20 years of phacoemulsification, posterior polar cataract is still perilous because of the difficulties. And even after 20 years of phacoemulsification, the postoperative adjustments of astigmatism is still not proper. So here we have the Femto advantage. The Femto advantage with the LOI now becoming gentler and gentler. A capsular rhexis being done, all the parameters getting to be supervised and set to the perfection of the patient. Just 1 second to 1.4 seconds for a capsular rhexis, neat, round, and circular. cataracts of different grades, grade 1, grade 2, grade 3, grade 4, grade 5, whatever you have, we have the femto advantage. And soft cataracts are no longer treacherous. At one point of time, difficulty in phacoemulsification of a soft cataract was so difficult. The bowl would sit back and would not let go. Here, you can chop the soft cataract by the femto laser. And that gives a speed to your phacoemulsification, and the difficulties that arise do not require excellent movers. The femto advantage in the hard cataracts, the dissipation of phacoemulsification energy that would definitely disturb the corneal endothelium is not much. And the hard cataracts can be emulsified very, very well, and it can be softened with the femtosecond laser, and thus leaving it safe for the corneal endothelium as well. The cataract just melts away, and you can see the phacoemulsification is much, much easier, and these tough nuclei definitely are a problem. So phaco to femto, and that's the way to go. Thank you. Thank you so much.
Thanks for that really nice talk, Dr. Partha. And I would like to welcome, I think we have Dr. Mahipal sir joining us, who's just been at the starting of the IIRSI webinar as well on corneal eye donation. Welcome, Dr. Mahipal sir. And we took the liberty of starting off, waiting for you. I'll request you to, say a few words on today's webinar about Partha's talk, and also the brief introduction which I had requested you to please give to this webinar.
Thank you very much, Gaurav. Sorry, I had to just get the iBanking webinar started for IIRSI. Good evening and welcome everybody. Thank you very much, all of you, for participating in this webinar, which we are going to look at what the present femto laser systems are offering us, and as to how things are going to move and how to best utilize these femto laser platforms. I think femto laser is the next gen of cataract surgery, and as things have progressed over time, that is gaining more and more acceptance with more and more units that have been put up at various places. Obviously, the new technology has some starting glitches, and which have been removed very satisfactorily. And I think there is more to it as the progress goes on with the femto laser assisted cataract surgery. I think what one has to realize is that femto laser cataract surgery in normal cases happens in a good manner. But I think the real challenging cases, when one comes around that is the time when actually the the advantages of femto laser come out in reality as to how it is going to help us in challenging cases. So I think majority of the cataract surgeons who are high volume cataract surgeons have moved on to this particular technique. And as time goes, I think the technology cost may come down, as also the patient interface cost would come down. And therefore it might over time, I would say maybe over the next 5-7 years, become the gold standard for doing cataract surgery. And we have great speakers, and thank you very much, Dr. Sufak, for again joining us, and always a pleasure to have. And I can see Dr. Garewal, Kumar, Partha has already spoken. Sorry, Partha, I didn't listen to your talk. Sharat, Arul, Parikshat, Gitansha, everyone will be there. So let's have a lively session, and thank you everyone for participating in this webinar. Yeah, Gaurav.
Thanks, Mahipal sir. Partha gave an excellent talk, and I wanted to hear Dr. Grewal, who's been one of the pioneers of laser cataract surgery, or maybe the early adopters of laser cataract surgery. Dr. Grewal sir, where do we stand today with laser cataract surgery? Although Partha has very nicely said, if any things that you would like to add. Dr. Grewal was here just now. I think I don't see him for a moment. So we'll take Dr. Rohit Prakash's tips here. Okay, Dr. Grewal sir, would you like to comment on Partha's talk and where we are today? What do you see has changed in the last 5-6 years that femto cataract surgery has been around?
Let me congratulate Partha for a very, very succinct, clear message that he has tried to convey. And I like the way he has put it, that even after 2 years in surgery, one still feels the need for doing the flags. And that is what that is what speaks a lot thought about the procedure. It is the ease of doing the procedure which makes the difference. And the ease of doing a procedure is inversely proportional to the complication rate. I become comfortable with the procedure and I feel confident when I know that this procedure gives me less complication than the B procedure. The second point is that Dr. Pathor was the cost justification. I have only one point to say on that cost justification is a perception of the user, not the perception of the surgeon. And also that why deny those who can afford, why deny them something which we all know and we are convinced that it is much better. So thank you, Partha, for setting the ball rolling with an excellent presentation. Thank you.
Thank you, sir. Thank you.
Thanks, Grewal sir. I think for the sake of time, I would have loved to ask a couple of other panelists, but I'm sure we'll all get a chance to, chip in with our views. And I'll now take this opportunity to invite. We have 5 minutes for each of our speakers, followed by 5 minutes for discussion, except our keynote speaker, who's going to share a lot of pearls, Dr. Chi. So we'll give her a little bit of extra time. And I'll now invite our next speaker, Dr. Kumar Doctor. Now, Kumar is a dear friend, and he's, I've learned a lot from him. When I started doing Phaco, he was one of the pioneers of Phaco from Mumbai. He's a stylish surgeon, always adopting new technologies first from the Dr. Eye Institute. And he has some amazing pearls to share. He has been doing a lot of small pupils with femto-assisted surgery, which conventionally is considered as one of the limitations of femto-assisted surgery. But for him, there is no limitation. He will show us how he uses femto technology to overcome even the small pupils. Dr. Kumar?
तुम्हारा है कौन सा नंबर लास्ट नेक्स्ट है
Thank you, Gaurav. Thank you, Maipal, and thank you, the whole team, who have asked me to participate in this. I'm going to talk on small pupil and femto. So I'm going to show two videos. So this is a video, you'll think that the pupil is not that small. How to go about that and what happens here is what I'm going to show. So here I'm showing the femto part of it, and you can see that the pupil is not all that large. So let's measure this pupil and find out what actually happens. So actually we can measure the pupil. And here if you see that the pupil is around 5, as you can see here, the pupil, and then it tells you that you are intersecting the iris. So kindly rechange. So we rechange that part. So you can see that I'm going ahead, I'm going to scan, and this is called the scan position. Once the scan happens, there's a size of the pupil that is measured. If it's too close to the iris, it tells you it's too close. And that's the reason why now you can see that I made a 3.8 millimeter pupil size. 3.8 millimeter rhexis, and the pupil is around 5 millimeter. So I've made a smaller rhexis in a small pupil, and let us see what happens when we try to do femto in such cases. So this is what I'm trying to show here, that sometimes your pupil you think is just adequate. It's 5 millimeter in size. Technically, yes, it's good for us, and we can manage through this. And let's look at this clinically when we do this. So you can see that the rhexis is 3.8. The pupil is about 5 millimeter in size. I made a side port. I'm going ahead and making my incision, then removing the rhexis. And now in such case scenario, what will happen? So I've removed the rhexis, I'm doing my hydro procedure, and then I'm going ahead with phacoemulsification. So at this stage, I've not enlarged my 3.8 millimeter. You can see the whole iris. It's like a floppy iris. Okay, so this is what the pupils are not going to dilate. In such cases, the pupil normally comes down on you. What happens in this case also you'll be able to see. Here I'm going ahead. I've not used any extra tool, like no hooks, no rings. I'm going ahead and doing phacoemulsification. Once I complete my phacoemulsification, the tricky part comes to the IA. So now you can see that the pupil has further come down, and the pupil has almost become 4 millimeter in size. As I had mentioned earlier, that the rhexis was 3.8 millimeter, and now the rhexis and the pupil are almost matching. So the pupil, as time goes by, keeps coming down. Not to worry, we can still go ahead, do phacoemulsification in such a scenario. We finish phacoemulsification, and then comes the tricky part of doing IA. So here I'm showing a technique of a coaxial IA. Some of you are now used to bimanual. I'm also doing bimanual, but the old procedure we had only coaxial. Bimanual was invented later. So here I'm going ahead and just removing the epinucleus. Once that is done, we go ahead and do IA. Now the biggest advantage of doing the coaxial IA is in my left hand is free, so I can actually retract the iris, go below. Now, the disadvantage here is that the cortical fibers are actually cut off at the level of the rexis at about 300 microns below. So you'll actually have to find the edge of the rexis, go below that and hold the cortex and strip it off. So this is a small rexis, again 3.8 millimeter in size, through which I finished phacoemulsification, and now I'm doing a IA, which is a coaxial IA, making sure that we don't hold the rexis margin, going ahead and doing phacoemulsification, going ahead and putting the lens in the bag. Now, as we all know, to prevent capsular phimosis, this rexis of 3.8 millimeter is not good enough. So it has to be enlarged. So once I've placed the lens, what I'm doing here is going to make a little nick in the rexis and then enlarge the rexis to the size that is required of about 5.5 or 5.75 millimeter in size to prevent capsular phimosis. So here again, it's a bimanual technique. I'm using a Besset's Y in the left hand. I'm going ahead and enlarging the rexis so that the margin just overlaps the optical size. So this is a scenario where your pupil size is about 5 millimeters. I still went ahead and did Femto. It's quite easy, quite possible without anything actually happening. This is just a viscoelastic removal, and this happens quite well. So now I'm going to show you one more case. So this is a tough case. And the patient came to me, and this is, I'll just say with all the features, no financial interest in any of this. Patient, and I call it challenging the challenge. So you can see sphincter atrophy. And this case was the patient came to with irregular shallow anterior chamber, a small pupil, angle closure attack of glaucoma. Patient has prostate, had peripheral iridectomy, a hard cataract, and we noted a subluxation. And the patient wished to have a femto. So this is a combination of all the things that are there. And now in such a scenario, what are we going to do? So pupil doesn't dilate more than this. And you can see irregular shallow anterior chamber. We can see a peripheral iridectomy, a sphincter atrophy. And on slit lamp examination, you can see the donesis that is present. This is all that the pupil dilates. It's not a soft cataract, mind you, friends. Now the question here is what to do. So here I went ahead with the registration. Once the registration is there, I made an incision of 2.8 millimeters, went ahead and put a Malugan ring. And at this stage, I will pause here, then go ahead and put a viscoelastic along the inner lip of the incision and form your chamber with BSS. Now I shift the patient. Luckily, my femto is in the operation theater itself, so patient doesn't go out of the operation theater at all. You can see on the right-hand side, you can see that there's a subluxation. You can see the position of the iris. It's one place, it's much deeper anterior chamber than the other side. Again, I go ahead, you can see the Malugan ring in place. Mind you, friends, sterile conditions, no suture taken, inner lip protected with the viscoelastic. Go ahead and do your CCC. Go ahead and do your fragmentation. Once your CCC is done, we bring the patient back to the operation table where the microscope is there. Go ahead and do your phacoemulsification. Now at this stage, I found some amount of donesis. When I found this donesis, I decided that I'll support the bag a little bit, and then went ahead and did phacoemulsification. I also needed more support superiorly, and that's the reason why I put one more hook. So I have the Malugan ring in place. I've done phacoemulsification. I have two hooks in place. I'm removing the epinucleus, and then I'm going ahead and doing my bimanual IA. Once the bimanual IA is done, I need to put an endocapsular ring. So mind you, here we have the hooks in place, bimanual done, phaco done. Go ahead and place the endocapsular ring. At this stage, if it was a capsular hook, I would have to loosen it. Since these are actually iris hooks holding on to the edge, I would prefer to use capsular hooks, but at that stage I had this. I went ahead, I put an endocapsular ring supporting the nasal side, which was the subluxated side. Go ahead and put the lens in the place in the bag. So once the lens is placed in the bag, again, I would like to place the lens horizontally because the haptics of the lens will give additional support. So the subluxation was nasal from this side to this side where the hooks are actually placed. Same region, I'm going to go ahead and place the haptic of the IOL. Then remove the hooks, and once that is done, go ahead and remove the Malugan ring. And I'd like to show the first day. I think there is a first day post-op picture. You can see a little bit of SK superiorly, and these patients do very, very well. So the take-home message here is, nowadays I would prefer to use a BHEX ring because we can place a ring to a 0.75 millimeter wound. No need for sutures. You can still maintain a sterile condition. Do not place viscoelastic in the anterior chamber before you want to do your femto because the femto energy will be eaten away by the viscoelastic. So always form the anterior chamber with BSS. The inner lip of the incision can be sealed with a viscoelastic like a Hilon GV. Energy settings may be increased during femto for the nucleus segregation if necessary. And you may need to use a dye so that you can see the margins of the CCC very well. There is actually no contraindication now to do a femto in a subluxated or in a small pupil with subluxation. And it's quite possible to make life comfortable, even if other comorbidities, this word has become very popular now, comorbidity of eye conditions, if they coexist. So femto does make your life much more easier, even in small pupils and tough scenarios. Thank you for your attention. I'll stop sharing and then we can go ahead.
Thank you very much, Kumar. I think you showed a wonderful video regarding small pupils. So as you have rightly said that you don't feel that today if you have a small pupil and you have to put a ring, you can go back and do the procedures. Just to ask you for a clarification, would you want to, how would you keep the chamber tight? Would you want to leave the viscoelastic in there, or would you want to remove it and put a suture and things like that? And would you want to do anything on the energy settings?
So two things I mentioned. One is, even if I take a 2.2 millimeter incision and if I put a Malugan ring, I will put a Helon GV along the inner lip and form the chamber with BSS, and it remains quite well formed and I don't need to take a suture. If we are still not sure and not secure, then one can go ahead and take a suture and then shift the patient. But with the BHEX ring that is now.
No, I was talking about when you said about Helon GV, or you leave behind a viscoelastic, if you leave behind, would you want to play with the energy setting? Would the energy setting need to be increased?
Yes, so you have to increase, but the Helon GV I'm leaving is very, very little along the inner lip only. So I'm not filling the chamber with it. I've done that mistake once, Mahipal, and I filled the whole chamber with a viscoelastic. It actually flattened the anterior capsule. And then the scan could not even find that anterior capsule. And it kept searching for this thing. Of course, it was a mistake in the first stage. And then I realized that it is the BSS that has to be used to form the anterior chamber. But now with the BX ring, now we just need a small side port. So all these issues are sorted. If we are sure that you need a suture, one can still take a suture and then take the patient back to the femto. The suture will make it more watertight. Then you don't need to use viscoelastic at all. But if you do use viscoelastic, then yes, the energy setting has to be increased.
So could you also tell the people who are listening as to the various measurements or the centration that you can get on the Catalyst platform as regards scanned capsule center, pupil center, manual, etc.? Could you just elaborate a little bit on that?
So the software here actually detects the margin of the iris, and then it decides to perform the rexes along that. What it actually is doing is scanning the whole thickness of the whole lens, and then deciding the center of the lens, the anatomical center of the lens, and then making the rexes around it. So what happened in this case, the first case, the pupil was 5 millimeter in size. And that's the reason why the computer itself decided to customize the rexes smaller by 1 millimeter than the size of the pupil. And that's a safety margin that is built inside the system. And that prevents us from hitting the femto energy to the margin of the iris. So that's one more thing that is there, that is built in. We can go ahead and do a manual centration. You can move the rexes manually, right or left, depending, again, not related to the pupil, but depending on the subluxation area, away from the subluxation, larger in size, smaller in size. So you can actually move your finger on the screen and decide the size and the position of the rexes throughout the procedure and before shooting the femto laser.
Yeah, so basically, if you want to fool the machine, you can also do that, because the machine leaves a margin of 1 millimeter from the size of the pupil. And actually, if you can manually increase the size of the pupil and then actually see where the rexes is, so you can kind of reduce it to maybe 0.5 or 0.3 from the rim of the pupil. So you can actually increase the by the default rexes that is happening by a little bit. And as you rightly said, it can scan the entire capsule. You can place the capsule or be on the center of the scanned capsule, or on the limbus center, or the pupil center, or you can do it manually. So it's just a very intuitive touch, single touch thing, which I find much better in this machine as compared to the other machines. Gaurav, any
Absolutely,
questions?
sir. So I just thought that I'll ask one or two of the panelists what's the smallest pupil size that they would proceed with femto. So Dr. Sharad Babu, you're doing a good number of surgeries. At what pupil size would you not want to proceed with femto, or switch to a Phaco, or would you like to comment?
Yeah, if it is less than 3.5, I never go with the catalyst. So even the patient prefers, I advise them just a Phaco, and then with the pupil dilators, with the hooks, I go ahead and then do the Phaco surgery.
And Dr. Chi, what since you're the Olympic gold medalist, what smallest pupil size do you prefer on the Catalyst or the femtosecond platform?
No, I rather expand the pupil so that I'm comfortable with the size rather than compromise. But I think the smallest I would really be happy with. I've done like 4.2, 4.3 mm capsulotomies. Yeah. But those I tend to enlarge later.
Right. So I think small pupils are no longer, something which are going to stop us from doing Femto and gaining the benefits for the patient for all that Femto delivers. And Dr. Rohit wants to say something. You know, he's a pioneer on 2 platforms, just like some others of us. And Dr. Rohit, what's the difference that you see between the older platform and the new platform as far as small pupils go?
I call it Femto 1 phase and the Femto 2 phase, like lockdown 1, lockdown 2 phase, whatever it is. I think Dr. Kumar showed excellent videos. Well, when it comes to small pupil, it is not the size of the pupil, and it is the associated comorbidities which might be there. If it happens to be a plain IFIS in patients using tamsulosin, we really don't want to have a larger axis because you don't want fluid to have access to the mid-periphery dilator zone of the iris, which can cause floppiness and everything. So in those cases wherein it is IFIS with no associated condition, 4.8, even 3.8, diameter is adequate for me. In patients with associated pseudoexfoliation and hard cataracts, where, I would not venture in for a small pupil without any dilating aids. Well, coming to the second part of the story, which is the Melquin ring, we do not have, Femto flax in the same unit, in the same OT. So I am a bit hesitant of, using, putting a ring and using a saline and suturing and taking the patient out and then taking it in. Well, excellent videos. I compliment Kumar as always. He's always there at the top. Thank you very much.
Thanks, Rohit sir. I think I should move on to inviting another of our brilliant speakers. And so let me just do a short introduction of our next speaker. So Dr. Gitancha Sachdev. Now, she is being young, but she's a very talented academician and a very gifted surgeon. And at this young age, she's been able to, demonstrate excellent live surgery that I've been able to see a few times and has so many publications. She's academic in charge and consultant at the Eye Foundation, Coimbatore. And she's going to speak on a very difficult subject today. And that is something which everybody would be scared of, whether they're doing SICS or Phaco or Femto. That's posterior polar cataracts. And I think, as we've gone along with Femto, many of us have found that posterior polar cataracts have become our preferred way of operating. So I'll invite Dr. Gitancha to please go ahead and share her screen and tell us why she prefers Femto for posterior polar cataracts.
Thank you so very much, sir, for this very kind introduction. At the outset, I'd like to thank the organizing committee for this opportunity. Is my screen visible?
Yes, please go ahead.
So today my topic would be flax in posterior polar cataracts. I have no financial disclosure. Now we're all aware that the posterior polar cataract has an increased propensity for an intraoperative posterior capsular dehiscence, which makes it a challenging case to handle. Maintaining a closed, stable system and low fluidics are important principles that one needs to keep in mind. However, the Femto platform has a distinct advantage over the conventional phacoemulsification in certain steps, such as giving us a perfect rhexis and the Femto delineation, which negates the need for further hydrodelineation or nuclear fractus. Now, having a central perfect rhexis is important because you need an adequate sulcus in the eventuality of a posterior capsule dehiscence. Again, as has been alluded to earlier, the rhexis can be customized, and some surgeons prefer an oval shape, which gives you more space for maneuvering the epinuclear plate from the capsular fornices. The next important step would be the hydrodelineation. Now, when we perform it manually, there might be misdirection of fluid with an inadvertent hydrodissection and a subsequent capsular blowout. The Femto delineation, on the other hand, is exceedingly precise. You get the epinucleus at the exact dimension that you need, and it is uniform throughout. Moreover, the cavitation bubbles that are produced give a certain amount of a pneumodissection, which virtually eliminates the need for a subsequent hydro procedure. The additional advantage of the epinucleus would be that it would give you a shield, which cushions the underlying posterior capsule, from all the hydraulic and the mechanical forces during the phacoemulsification process. Now, this femto delineation technique, which Dr. Partha sir had alluded to earlier, was introduced by Dr. Basavara, where you can see that there were 3 concentric cylindrical patterns. Nuclear softening can additionally be done in cases of associated nuclear sclerosis. So this was described by Dr. Titiar, wherein along with the cylindrical patterns, he has also broken it into various fragments. So this is a video which demonstrates the fragments that have been formed. You can see that the cleavage plane has already been formed by the femto, because of which the pieces can be removed easily without any manipulation or rotation. The inner core is removed first, and while doing that, these outer layers form a cushion for the posterior capsule underneath. The thick epinuclear plate is then finally removed. One of the advantages that I like best is the inbuilt ASOCT. It is a high definition anterior segment imaging, wherein you can get the integrity of the posterior capsule before actually starting the surgery. Now, this can be done at any stage, be it preoperatively or with the inbuilt femtosecond laser ASOCT, or even intraoperatively. Now, a handful of studies have shown the use of a preoperative ASOCT in eyes with posterior polar and conventional phacoemulsification. There were certain limitations, be it either a retrospective study with multiple surgeons or a limited cohort, or in certain cases, PPCs larger than 4 millimeters were excluded. Now, to overcome all of these limitations, we did a prospective single surgeon study wherein a femtosecond laser platform was used for the posterior polar cataracts of all dimensions with or without association with nuclear sclerosis. So we had a cohort of 50 eyes. Now, what was important was that the sensitivity and the negative predictive value was 100%, which essentially means that if you have what looks like an intact capsule on the ASOCT, the risk of an intraoperative PCR was 0. The 4 eyes that developed the PCR had an opacity which was greater than 4 millimeters. The false positives could essentially be because of an aftershadowing, because of a dense posterior plaque, which may result in the appearance of a non-intact posterior capsule. Now, this is a short video which will just summarize all the points that I've highlighted. You can see a high definition ASOCT and a discontinuation in the posterior capsule. The epinuclear sheet of 100 microns is made by increasing the posterior offset. Again, you can have predictable has been done in this case with sclerosis. Now, on table, you can see a free-floating capsulotomy. This is subsequently bunched up to the center and is then removed. While doing the phaco, no fluidics are used. You can see that the prefractured lines make it exceedingly easy to separate the pieces and remove it without any excessive manipulation or rotation whatsoever. The softening additionally will drastically reduce your effective phaco time. Now, once the inner layer is removed, you can see that the epinucleus is still forming a good protective shield to the underlying posterior capsule. This is then wheeled out and is removed in toto from the capsular fornices. One should always maintain the principles of closed chamber and insert viscoelastic before removing any instruments. Although coaxial has been used in this case, a bimanual would be preferred in the event of a PCR. A 3-piece IOL is then placed in the sulcus, and because of this wonderful capsulotomy, you can have a 360-degree overlap. So I'd just like to conclude by saying that the femtosecond has resulted in an increased safety and a repeatability in the posterior polar cataracts. And the on-screen imaging actually gives you a fair idea as to which eyes will go on to develop an intraoperative capsular rent. Thank you.
Thank you.
Thanks, Gitansha. And Dr. Maipal, sir, can you please, because you have a lot of experience with posterior polar cataracts, can you please drive this discussion?
So actually, there's a lot of interest ever since the Femto came onto the posterior polar as regards the imaging technology, and just now we are also evaluating whether the pre-op imaging can also help as much as we have the intra-op imaging that of the OCT, because it gives you a 3-dimensional image, and it's almost 100% that we have been able to find out whether there is a pre-existing defect or not. And when we are doing this particular procedure, at that time, I'm very, very comfortable in telling my anesthetic whether to give a peribulbar block or not, depending upon whether there is a rent or not. And I can at that particular moment tell. So it is very important for us to even have pre-operative diagnostic modalities of the OCT that are available, whether it's the IOL Master 700 is also giving you a great image. So I think the imaging has really improved the outcomes. And there are several papers, and including in our study, which is not published, that ever since we have been using the femto laser for posterior polar, the incidence of nuclear drop is almost 0%. So I think Titial Abe has also reported this particular thing, that the nucleus drop does not happen because you are very careful and you have visualized the whole thing. So I think that, yeah, Cyrus, you wanted to say something.
Yeah, sir, I have a question. I saw Dr. Titial sir doing the surgery. That looks like the Alcon system, which is doing that circular kind of disassembly. Can the Catalyst system do the same thing?
I think it can do. You will have to open it. It's not an open system that where you can do that, but there is nothing stopping that concentric rings. But that concentric rings is in the Lensex system, yes. As of now, it's not as a standard of care in the cataracts.
What pattern would you prefer in the Catalyst to handle?
I just prefer a normal pattern as long as I have the epinuclear cushion, so it really does not matter. So what they are trying to say is that these concentric rings is doing a pneumodissection, which whatever pattern you are following, they will do a pneumodissection and you won't get a hydrodissection that is there. It's more of a delineation pneumodissection that happens, irrespective of whatever. So you can have 6 quadrants, you can have with softening whatever you want. So the only thing is to preserve the epinuclear cushion right till the end. And that is why you don't have a nuclear drop, that even without rotating or by putting any fluid, you would be able to take out all the quadrants of the nucleus that is there. Rohit, you have any comments on how you feel about posterior polars?
I think I have to compliment you for this femtosecond laser, wherein you have that, where you have used the integrated anterior segment OCT to the fullest. And I tell you, we have also started using it since I saw your paper, and we found that it is really worthwhile, where we come to know whether the posterior capsule is intact or not. So with the offsetting of 800 or so, you don't need to have 3 cylinders. Even a single 800 micron should suffice for that matter. And the best part of the story is you don't need to rotate also. And we end up with a small, the posterior capsular extension is also not that profound. So you can end up with a posterior capsular rexis also in such a situation. So I think it has been a good, landmark thing which you have come out with.
Anyone else has any comments?
I think Dr. Grewal also uses, has been preferring this thing, and somehow I don't see him. Grewal sir, before you leave, we want to utilize you to the fullest. What's your, and I see you do very elegant, posterior rexis with the platform as well, where, managing a primary posterior rexis in congenital cataract. So would love your views on this as well.
I think it was an excellent presentation and it touched on all the important points. As far as the pneumodissection is concerned, pneumodissection depends upon how much cuts you are doing. It also depends a lot on how much hard the cataract is. If you have just bubbles staying within the lines or the nucleotomy, and so what I do in these cases, I'll be just making the radial cuts, and that's it. I'll not be doing any softening at all in these cases, and I would have a minimum bubbling, set the energy so that there is minimum bubbling. That's it.
Wonderful, sir. And I think, for me also, posterior polar cataracts, I think femto-assisted cataract surgery is my first choice. And before we move on, Dr. Chi, would you like to chip in with any of your pearls, or are you going to tell us in your talk itself?
I'll tell you more in my talk, but I just want to perhaps have this clarified. How do you tell that the posterior capsule is intact on that OCT?
So essentially, there shouldn't be any discontinuation in the posterior capsular line, and the plaque should not be adherent to the underlying posterior capsule. So you'll be able to follow the entire posterior capsule throughout. There should be no areas of adherence, or there should be no skip areas or missing areas wherein it appears dark?
Okay, I mean, I've seen those that have gone beyond that line and yet have not ruptured. And later, when I give my talk, you'll see some interesting cases.
Yeah, we did find a few false positives as well, because there are sometimes artifacts or the aftershadow itself can give a blackening effect of the posterior capsular underneath. The important point of what we had published was the negative predictive value, which is essentially to say that if the posterior capsule looks intact, there will not be an intraoperative PCR. We did not comment on the fact that if it looks discontinuous, there will definitely be a PCR. So we could have false positives, but the negative predictive value was 100%.
Okay, but just watch my posterior polar videos later and maybe give you a comment. Thanks.
Wonderful. We look forward. I think, Maipal sir, should we go on to the next talk? I think we're a little behind schedule. So I'll invite our next speaker, and we have again a brilliant surgeon. One moment. I think I got the wrong screen. One moment, please. Why is this screen coming up? I'm sorry. So I think there is a problem with that. One moment, give me a moment, please. So I'm going to invite Dr. Arulmozhi Verman, who is again a very, very renowned phaco surgeon, very talented phaco surgeon and refractive surgeon, and I really respect his wisdom and all he shares. And he's the managing director of the UMA Eye Clinic in Chennai, who's again one of the brilliant femto cataract surgeons and a brilliant phaco surgeon. So let's see why he prefers to use the Femto platform for his difficult, challenging cases with capsular pathologies. Dr. Arulmozhi, sir.
Thank you, Gaurav, for inviting me. I'm sharing my screen. That's good. Okay. So flax and pathological capsules, flax, the capsulotomy is the strong point of flax, of course. The very strong point also is the fact that it does lens softening. But if you don't get a capsulotomy, then you've lost the strength of the flax itself. So often when the capsule is not so normal, or it is, in other words, pathological, it could be difficult. One of them could be, of course, increased intrareticular pressure. That will be handled differently. There's a different speaker for that. So I would say irregular capsular surface or any kind of adhesion of the capsule to the underlying lenticular material, or a calcification or folds, they would probably classify to be a pathological situation, which could interfere with capsulotomy and make it difficult either way with the flax, and it could actually make it almost impossible without flax. It's not going forward. Okay, fine. Here we are. So what do? We have to look for the capsulotomy settings. You probably, in these situations, you may have to alter the size to avoid an area of calcification, or avoid an area of adhesion. That would be prudent. You could go back and do that. Most important, you may have to play with the depth. The depth of the cylinder, that's the cut that is made with the femtosecond laser, by default is 600 microns. You can vary it from 1 mm, that's 1000 microns, to 200 microns. Some of us shift from 600 to 400, and we also can change the spot spacing, which is kept at 10 micron spots. You can make it 15 and then reduce it from 600 to 400 in cases where you have an intumescent lens, where you want the rhexis passed before the decompression of the intralenticular pressure would change the position of the capsule. It's the opposite that you have to do when you have a pathology in the capsule. You may have to go back, look at the OCT, and very carefully readjust the position of the OCT, the defaults, to a more precise level, so that you are on the capsule and the machine is not getting cheated by the pathology on the capsule. You may be better off from increasing the cylinder from 600 to 800 microns, or even to 1000 microns. And the spot spacing can be kept at 10, or you could be keeping it at 15. When you have a deeper cylinder, the chances of any skip areas that would occur because of folds in the capsule, or by bringing the spot spacing closer, you'll be able to cut even capsules that are otherwise calcified or an area that's fibrosed. So one has to look at these things, look around slit lamp, decide, and change these settings. You can do it on the fly, but you could probably do it earlier on the machine before you get to it. So this is there, which shows you the vertical spot spacing, shows 15, and the incision depth as 600. This is the what you would have as default. Change it as per your need. You probably sometimes have to increase this in these kind of situations. Look at this. This is exactly what we're getting at. You should make sure that this 600 microns or 800 microns or whatever you keep is enough to go through the thickened capsule or the abnormal capsule. So please check both the anterior and posterior OCT parameters. Look at the lines, readjust the indents to correct the settings if necessary, because you want that to be perfect. You don't want the machine to be misled by abnormal reflections that are coming off from tissue that's not absolutely normal. So here we have a situation here. You'll find that the pupil is large. It's extremely large, quite good, nice pupil. You'll easily get a 5.5 millimeter rhexis, but you would find that everything is going wrong here. The OCT is not able to look at the anterior, is not able to look at the posterior, and it decides, because of the wrinkles on the capsule, it suddenly decides that the pupil is much smaller than it actually is, and gives you all kinds of error messages. You can see the ring here, the pupil is about 1 millimeter smaller, what is drawn by the machine, than the actual pupil, which is more than 1 millimeter larger. Go back, look at these things, reset them on the machine. The anterior setting has to be redone because you'll find that the capsule is thickened, it's kind of abnormal there, reset that. I've done the posterior also in this case, that also was pretty much abnormal. It could not penetrate a very dense cataract. Then we had to go back and make the rhexis smaller because the machine was reading the pupil to be much smaller. Once all the settings were done, the rest of it becomes pretty much normal. But of course, this was a very, very dense and mature cataract. Not much of lens softening took place. So you see here that the pupil is so large, the rhexis was small. Here I gingerly opened up thinking I would have some problem on the capsule. I did not have any issues. So this is primarily due to the fact that I reset the OCT levels and reset the cylinder down to a deeper level too. So that makes the rest of the emulsification pretty much simple, though the softening was very minimal. And with a good, the rhexis was about 5 or 4.8 millimeters, not an issue. So we had a good result at the end. With the lens that centered very well. So to sum it up, if you're doing flax capsulotomy or doing flax in abnormal capsule, please increase or decrease the depth of the cylinder appropriately. In some cases, you may have to increase it, some you may have to decrease it. Appropriate spot spacing, where you feel that the capsule is very thick or it is folded over or it is fibrous, space it down to the closest spacing possible, that's 10 microns. Check on the OCT alignments and make sure the alignment is perfect, and so you can get the best results. So if you do all of these, you can get the capsulotomy even in pathological settings of your capsule. So LOI is the most important thing here. The cornea not being disturbed makes the capsulotomy absolutely safe even in difficult situations. Thank you.
Thanks, Arul sir. Is there any situation where you would not, any capsular situation where you would not want to use the femtosecond platform?
Sometimes you have a wrinkled capsule and it is fibrous as well as calcified. As nothing is going to work, you probably need to go and use a scissor, tear where possible, use a scissor and get the best rhexis possible.
I've seen Dr. Ramamurthy do one very difficult case like that. Dr. Grewal wanted to say something.
Yeah, thank you. Again, a good presentation. if you have, I'll just mention 3 situations. First is a fibrous capsule. In this situation, I'll increase the energy and also increase the cylinder height. But my increase in energy will be more than the increase in the cylinder height. The second situation can be a wrinkle capsule where I'll be increasing the cylinder height more, but also I'll be increasing the energy. A third situation of the capsule can be a tense capsule, that is the Intumescent cataract, where I'll only increase the cylinder height and I'll not be changing the energy. So you have to titrate depending upon how the capsule it is, how it appears on slit lamp, and how much the contour line thickening you can see. You have to adjust the parameter accordingly. Do you want more energy, you want more cutting, or you want the greater movement of the cylinder? Thank you.
Thanks, sir. And I think Dr. Ramamurthy is the right person to put this question to. Any special pearls on handling difficult capsules, Ramamurthy sir, and any preferences on why you choose Femto over, doing a manual rexis or some other form of rexis?
Sorry, I just joined midway through the talk. Sorry for coming in late. So I hope I heard that several points were made about the laser settings. I would agree with the fact that usually I use a 300 micron offset on either side, increasing it, and as Dr. Grewal mentioned, maybe use higher energy. But I would also be very careful about what I do under the during my phaco emulsification. These difficult cases, I would invariably stain the capsule because very often it is not a free floating capsule that you have. And especially if you have used a grid pattern, sometimes the areas of tags are completely hidden. So staining the capsule exactly tells you the status of the capsule. Usually I use a down-up technique to just pick up the capsule and remove this. In these cases, I'll never do that. I'll just go through a side port using a 26 gauge needle the way I do a capsular rexis and gently peel it off. Because even if there are some additions over there, with the usual rexis maneuvers, I can have remove the capsule in toto. In case you pull on the capsule with tags over there, that's when there is risk of there being a wraparound and the capsular rexis running off. So these are some things I'll do. But even as you said, even in very difficult cases where there is extreme additions, I feel that a femtosecond platform is a good way to go, because even though you may not have a free-floating rexis, you often end up getting a template. Subsequently, you have a round template, and subsequently, either by using scissors or with your needle, you can get away with a nice round capsular rexis. As far as intumescent intumescent cataracts are concerned, most often there's a great indication for using femtosecond laser. But there have been occasions where, in spite of the fact that you get a capsular rexis in 1 second, there's been a gush of fluid, and that itself has caused the capsule to disrupt. These are situations where I will invariably stain the capsule and make sure that what exactly is the status before proceeding with the surgery.
Arul, there is a question by one of the people, I think Dr. Pangarkar or somebody. Is there any criticality as regards the AC depth when you would not do a capsulotomy, or there is a machine default which does not allow you to do in case the AC depth is very, very small?
How small is the question? I guess most shallow ACs are about 2.5. You can still go ahead with that. If you have some kind of an intumescent lens and the anterior chamber is flat, then that's a different issue. I don't think there's any kind of an issue with the normal so-called shallow chambers. They don't make a difference here.
Kumar, you wanted to say something?
So I've done a micro-ophthalmos where the cornea was 58 and the ACD was 2.2 and the lens thickness was 4.8. Believe you me, the machine gets all confused because the machine does not understand a 58 keratometry. So you have to actually level each level. So you have to get the anterior cornea, posterior cornea, iris, anterior lens capsule and posterior lens capsule, because the machine gets completely confused and it keeps saying beyond normal limits, beyond normal limits. So you have to actually override the machine and then only it will allow you to do this. So I've done one case like this and I did it successfully, but these are the problems that I faced.
So actually, I think there are a couple of papers that have come, and we also believe that especially if you have lens-induced glaucoma or you have hypermature cataracts, that is a treatment of choice because you're not opening the chamber. A capsulotomy that is done, especially in intumescent, as also for phacomorphic glaucoma, that this is a treatment of choice that you can do. Gaurav, you wanted to say something?
Yes, sir. Sir, I wanted to ask you only, in fact, that between the 26 cystitome and the microrhexis forceps, if you are faced with a situation where, your rhexis is not complete, or, for example, in an RKI or in an intumescent cataract where the template is there, but it's not complete, would you prefer to kind of tear it with the 26 and, just like you do a rhexis, or you would prefer to hold it with a microrhexis forceps and then tear it, similarly without pulling on it, but like, running it around like a rhexis? What gives you better control and less risk of, broken rhexis?
So actually, both the techniques work very well because there are. So what Dr. Ramamurthy said is actually a very, very valid point, that you should always inject Tripandu even if you consider that it is complete, so that you have. So actually, the pull is what is important. So even with a needle, you can pull it towards the center. And you should not be far away from the tearing edge of the capsular rhexis, or microforceps from the side port or a needle from the side port. You don't want to lose the chamber. Both of them work very well. So I think especially if you have a fibrotic capsule, then I will use a microforceps because this amount of force that you need to require would be slightly more. But usually in intumescent, there is hardly a problem. At the time when you see like I would say a nuclear blast, when the fluid comes out, you know that this is the area where there is a likelihood of the capsulotomy not be complete. So you need to be very, very watchful. And as Dr. Garewal said, increasing the cylinder is something very, very important, so that even if there is a deflation of the chamber at that particular time, there is an enough default that is there instead of the 400 that you have. If you have a default of 800 or maybe even 1 millimeter, under those circumstances, you will, even if it collapses, you will still get a cut. So that is. Sorry.
Sorry.
Yes, Dr. G.
Yeah, I just want to make a point. I'm not sure that if you increase your treatment bandwidth that it would really help, because the problem is when you puncture the capsule with the laser, the fluid actually escapes and your capsule drops. So the laser is coming from within the nucleus towards the cornea. So if this level drops, you would have actually bypassed your treatment. So I'm not really sure that if you increase, that is going to be able to still treat your anterior capsule.
No, but Dr. Chi, the point is that if this is the lower default, this is the upper default. So if you have a 400, if this is the capsule, it will be 200 below and 200 above. So if you have say 800, so you will have 400 below. So it will compensate for a fall up to 400 or 500, which is half of the default setting that you're doing. So if your default setting is small, then the drop would be below that particular area.
But the moment you puncture, it will just drop below anything else, because you're treating from below upwards.
Agreed.
Maipal sir, what she's saying is that, because when you're coming from below above, even if you've set it quite away, below where the capsule is, somewhere it'll hit the somewhere it'll hit the capsule. The moment it reaches the lowest part of the capsule and it punctures, it goes below the treatment threshold, as it collapses. She has a point, but, that may happen only in those very liquidy, like Morgagnonian kind of cataracts, maybe not in the intumescent as much. I don't know. I mean, it would happen in those things where there's a lot of fluid just in the subcapsular area, and I don't know the correct answer to that, but yes, a very valid point.
The point is valid, but it is not something that it is at a, everything takes a little time. So point is, before the fluid actually comes down and before the fluid releases the pressure and the capsule sinks down, it does take microseconds. And by that time you have had the whole circle. It's not that the first moment where the first spot is being hit, that is the time where the fluid is going to come out. So it always takes, so if you even go back and watch your videos, it takes a little while for the fluid to come and for the capsule to drop down. So I think that is the default that is going to happen. Maybe Dr. Garewal, you would wish to comment on that?
I would like to say only one thing, especially after the comments by Chi, that I don't think we have enough information scientifically, high-speed cameras where we can actually say what is happening. Whatever we all have been saying is what we presume that it is going to happen.
No.
Can I differ?
Yes.
I've published this, all right? I think it's in the VGO, because I used to use the Victus. And the Victus is a real-time OCT, which gives you a cross-sectional view. So I played this slowly and watch the moment, there's any kind of liquid coming out of the capsule into the anterior chamber, the whole level drops. And if you read my paper, I will tell you whether that particular capsule has dropped or has actually stayed the same, or some capsules actually go upwards, depending on as correctly pointed out by Mahipal, the content within the capsular bag. So in Morganian cataracts, I think 5 out of 6 were all like only half cut because it was so liquefied. It escaped so rapidly, and the milk actually occluded, blocked the view and the treatment ability of the laser on the rest of the nucleus and the capsule.
In that way, I think the Catalyst really scores over the other platforms because, it has a very fast Rexes, it's over in a second. So I think we are much safer on the Catalyst compared to the older platform that I was working on. Dr. Chi, would you compare between the Victus and the Catalyst in the speed of the Rexes actually? Is there a difference?
There is definitely a difference, but still, I do not have always complete free-floating capsulotomies in the very, very liquefied cortex.
Yes, I agree. So I think we have to be very cautious in these places where, yes, Dr. Arul.
Yeah, that's where I wanted to differ. Would it make sense in an intumescent cataract not to increase the cylinder, but actually decrease it and increase the spacing from 10 to 15 so that the whole speed is much faster? It drops down to 0.8 seconds.
And increase the energy, maybe? I don't know. Dr. Chi can talk about that.
You're now going to do the whole cylinder in less than 1 second. 0.8 to 0.7 seconds is very, very fast. That's what I would choose to, and I've done that.
No, but Arul, the point is that if you are increasing the height, it is
not increasing. I'm actually decreasing.
I understand. What you are decreasing is something if you have actually increased the default, so it is going to pass over it again, right? So it has to. So therefore, the number of passes would see. It's the time that you are getting for the deflation of the capsule that is there, which when it is falling down, if you are outside the limit, that is the issue. So I would love to see Dr. Chi's paper, but conventionally that's what is thought. There is a second thought, as you are saying, that you should reduce the cylinder, but conventionally I think all the manufacturers are talking about increasing the cylinder height.
What about fooling the machine? You go back, look at the anterior capsule, drop down the anterior capsule level slightly.
Yes.
And then you can increase the cylinder or decrease it so that this is already starting at a lower level. The capsule drops, you still.
Let's try that.
Yeah, I think we are all trying to fool the machine with various things, small pupils and now the capsules. So I think, yes, Ramamurthy sir, and then I think we should go on.
No, I think, you increasing the offset, increasing the cylinder is necessary only when you have a slightly tilted lens or a tilted capsule. And that also maybe with the contour graded capsulotomy that is inherent in most of these machines, where they follow the contour of the capsule, it may not be necessary. And when you don't want a rexis getting disrupted, basically you want to finish the capsule or rexis as quickly as possible. And maybe I would not reduce the cylinder, but increasing it may be counterproductive because all the laser starts from the bottom and moves forward. And it gives more time for the fluid to come and allow the laser not to really touch the capsule properly. So maybe sticking on to our current settings and hoping for the best would be a good way. Dr. Chi in an earlier webinar made a comment that these intumescent cataracts, she doesn't prefer a LRCS. She either goes with a capsular. Or, would you like to comment on that?
Yeah, she just spoke about that actually, yes.
No, she doesn't use the machine. I mean,
I'll use it for intumescent, but not for Morganian. So actually, I was saying that the Zepto as well as the capsule laser might be better options because it's a more certain cut. Yeah, you're more certain to get a complete cut, especially the Zepto. I've seen David Chang do all these difficult cases with.
I think we have to go back to the Zepto. I didn't like it so much. I enjoy the LCS so much but I think now I should look at it again. So I think if everybody's okay with it, should we go on because we have still 7 more lectures to go, sir? Mahipal sir, should I go ahead? I think I'm supposed to speak next. So should I go ahead? Okay, I'll just share my screen. So I was going to speak on, I enjoy the Femto platform for all these indications that were discussed, and that remains my choice of for procedure. But in RK operated eyes, where actually most, most surgeons would be reluctant, and, it's counterintuitive to be using the LCS, laser cataract surgery in RK eyes for various reasons. The challenges in RK operated eyes could be, difficult biometry, which of course is not related to the procedure. Then the radial corneal incisions, which, make the surgery more complex, whether be it SICS or Phaco or LRCS. Now in laser cataract surgery, the corneal incisions will, probably, especially if they have significant opacification along them, will probably obstruct the laser beams from hitting the capsular axis, and you may be having uncut areas just below the corneal incisions, and that's how I thought it would be when I started doing laser cataract surgery. And then over the years, as I started using it more and more, I found that it was not so much of an issue. Then, of course, eyes with radial keratotomies are usually ones which are very high myopes, so their corneal shape has changed, and they have very deep chambers, and these are eyes where you can expect the chamber to be very deep during surgery. Maneuvers in the eye and overlocking of the incisions can cause these incisions to, more manipulation can cause these incisions to become leaky, because typically when you have a deep chamber, you will do more maneuvers in a much deeper way, and your Phaco handpiece may actually be tilting, going way down. And IOL injection itself, if you're using a slightly bigger incision or a tight incision, may open the wounds, because that itself. So essentially, even with femto assisted surgeries, you have difficulty with docking on a very flat cornea, and you may get rexostag. So there are a lot of challenges, and let's see how we can overcome them. I wanted to share a case which we operated a couple of months back. Now, this was, of course, an RK surgery done in 1998, and a few years later, followed up by the primary surgeon with LASIK as well. So it was a dual surgery which was done for residual myopia the patient had undergone. So keratometry was crazy, as you can see here, that it was a very, very flat cornea, which was evident. In fact, the lens tag had a lot of difficulty capturing the, corneal parameters. It was a very high myopic eye, 32 millimeters there. And in fact, it was predicting on the various formulas. No formula would actually work really well in this situation. But let's see how the pentacam looked. And this is how the pentacam looked. You can see that there's huge variation in the keratometries as well. And pachymetry is not very thin, so essentially that means the LASIK correction was not of a very high degree, and the left eye as well was very, very flat. So all the devices that we used the eye trace as well, would either not capture the keratometry or show vastly different parameters. So I took help actually from one of my friends, Saurabh Sani, who's in Delhi, and we tried to go back and use some of the different methods for calculation. And we also use the pentacam to go with the EKR and use that keratometry as well. So we finally came up with an IOL power vastly different from what most formulas were mentioning, and we decided to use a 23 diopters in the right eye and a 26 diopter in the left eye, very different from what all the other formulas were predicting. And I had to keep my fingers crossed and warn the patient. Now, of course, the surgery itself was very challenging as well. And this patient, you can see that these had a multi-cut RK incisions, and docking on these eyes can be very challenging. It's a very, very flat cornea, and one has to expect that you may have a loss suction as well. But we managed to get hold of this. I have had 2 instances of difficult docking in my RKIs, but I do a lot of RKIs. In Dehradun, we have a lot of patients who have undergone RK all the way from Indore and from Punjab, and we have a local friend who was a pioneer in refractive surgery with RK. And so this, you can see that the cornea is pretty flat, and you can usually make out these corneas, but the rest of it looks great. And the surgery proceeds fairly smoothly after that. So let me just go on to the next slide. Now, this is how it looks once you've done it. And you can see that the RK incisions are quite dramatic over there. And I prefer not to make femto-assisted incisions for these eyes. And I would like to make a limbal corneal incision as much as possible. But you can see that the space is very little. So if one could actually even go with a scleral valve, if you would like to do that. I prefer to do a limbal incision because in my hands it seems to work well. Now you have to be very careful with the capsular axis, as we discussed. You could have tags, and I have had 2 or 3 patients where they were attachments just under. So you have to be very, very gentle and very careful. Trying to get that capsular tag out. And if you do have any attachments over there, you have to be very careful, as everybody suggested. but I'm touchwood yet to have a broken rexus in an RKI. I have had one or two instances in an Intumescent cataract where I did laser-assisted cataract surgery. Now here the advantage is that you've already chopped the nucleus into smaller pieces, so the manipulations of the nucleus are also much less. And in RKIs, it always helps to do as little manipulations as possible. So if your rexus is already done, and if your nucleus is already broken into 6 pieces, it becomes very easy to bring these out. And you can work at low infusion bottle heights on most machines, new machines. Now you have to be very careful. I use a hydroimplantation. You can see the number of cuts on the RK, and I'm doing a wound assisted injection. In fact, the tip of my incision cartridge is actually practically just about touching the external lip of the wound. And with hydrophobic lenses, now you can see that I'm sealing my incisions very gently with the infusion on from the side port, so there are no fluctuations of the chamber. And then, of course, even the side ports, you have to be extremely careful and make sure that you get your incisions sealed nicely. And then you can check. I check it with my index finger, and I know that Dr. Ramamurthy likes to do that. We learned that from Dr. Blumenthal. And then you can do a trypan blue test to see if the wound leaks, especially in these RKIs where sometimes you may have a small leak, and then if you just wait for a few seconds, it'll settle. Otherwise, you can try to seal it again and check the pressure. So that way, I think in RKIs, I find a lot of value, and I actually try to convince patients that if they can go with a surgery which is femto assisted, I would even subsidize it for them if they were not able to afford it, because I get better outcomes when I use that. Now here is another small situation where I'm injecting a lens into this RK operated eye, hydroimplantation. So you can see that this is a toric lens. And so when you're doing toric IOLs in RKIs, which you should be very careful in doing if you are planning because of sometimes irregular astigmatism, yet if you're convinced that it's going to go well for you, you can femto assisted surgery again becomes very beneficial. In fact, if you look at this rexus, you'll see a small tag here. So one has to be careful that you don't get a broken rexus, especially when you're implanting the lens. And then I get better outcomes with these cases as well using the femto platform. And going on to my last 2 slides. So the cautions, of course, have to be followed when you're doing laser cataract surgery in RKIs. As I said, you have a flat cornea, so you have to pay good attention to docking. Be mentally prepared that there could be a suction loss, so be careful. And attention when removing the anterior capsular flap. You may have connections at the just under the RK incisions, but while theoretically it is very, very important, practically it is not as bad as it might look. Yeah, they work out pretty well. And then the incision has to be placed correctly, and very atraumatic IOL insertion and good wound management. You can try to seal the wounds with infusion on. It helps in keeping the chamber stable, and you can also see if there's any leak. And of course, if you have a leaky incision, you must suture it. You don't have much choice there. And take home pearls from my talk that I think LCS is laser cataract surgery is very beneficial, even in this situation, which seems counterintuitive. And I have experience of about 55, 60 eyes which are post-RK on the laser platform. It allows predictable rexus and good nuclear segmentation. So minimal maneuvers in the eye, less handling of incisions because many of the things are already done by the laser before you actually start the surgery, and more predictable outcomes. So I think I'm open to any questions. I know that some of you may not prefer this for RKIs, but I'm happy to answer them.
Thank you very much, Gaurav, for bringing out the points. I think you have rightly pointed out a couple of things, and that is that you could have skip areas below the RK incision, especially if they are also showing some opacification, and therefore trypan blue is necessary, and you just need to be a little more careful. You could increase the energy for the capsulotomy a little bit more, and the other thing is that try to avoid the incision. It's better to be posterior limbar or scleral rather than having corneal incisions with the femto. So I think those are important points, and I also the RK is done by your friends are all coming with cataracts to you and not to him.
Maybe they don't go back to the primary surgeon thinking that maybe my LASIK patients are going with their cataracts to somebody else. So, but yes, you are right, sir. And
anybody else have any comments?
I really liked how he was placing the Phaco probe, not moving it. It was drying. Your tissue handling was. I would really appreciate how you were handling the tissue, because you were putting less stress on the the incision by all means. 1 thing which by all means, which I would definitely say that in my practice, I am a very strong proponent of using a scleral incision for that matter, because that really helps. Because at times it's always better to err on the posterior side rather than ending up. Because I had a situation where two of my incisions opened up and they continue to open up. So if we can go slightly posteriorly for that matter, no doubt we are very, with your maneuverability, things look perfect. But for surgeons of lesser level, I would suggest that we should go in for the posterior one. Yeah.
No, I think sometimes we get these corneas often from outside, which have 32 incisions and things like that, where you just can't actually find any space between the incisions. Ideally, you need to look at the space where the incisions are maximally separated and maybe use that. But as you have rightly said, scleral or posterior limbal is the way to go. Should we move on, Gaurav?
Yes, sir, we should move on.
What was the refractive outcome in your first case? I mean,
okay, yeah. So I wanted to share that. It was amazing because this patient, we got in one eye, we managed to get the patient 0.5 myopic with about 1.5 cylinder, and in the second eye, he turned out to be 0.5 hyperopic. But it was amazing, and I really must thank my friend Saurabh. He's not, of course, here, but he is quite good at biometries, and he helped me out with this one. Otherwise, I would have sent to Warren Hill for this because it was beyond my. I tried all the formulas, I tried the online calculators, and I don't know if any of you have faced a situation where RK and LASIK done, and I don't know what Dr. Ramamurthy, you are an expert at biometries. What would you have? What method would you have used to check this?
We actually published a paper on this of post-classic and post-RK series of 3 cases, and fortunately again they landed up reasonably well. And most often we use the Barrett toric calculator, 2K toric calculator in these cases. And what you get in these cases is mostly a hyperopic surprise. So post-myopia, post-RK for myopia. So you go with the highest power possible. That's the reason I found that you also went with 24, 26, the highest power. So usually,
in fact, sir, here the Barrett's 2K was giving us just about 15 or 16. That's the funny part. And so when Saurabh Sani calculated this for me, and I found such a vast difference for me, it was I was not sure what should be right, because between 15, 16 and 23 and 26, there was a vast jump. And also which keratometries to use, because what would you have used as keratometry? They were ranging anywhere from 23, 24 till 30. Like the Auto K was giving me 30, 31. The Pentacam was giving between 26 to 27, and one of our other machines was giving something like 24 to 25. That was the dilemma, because that's what would change everything.
What was the optic zone size of the RKs? I mean, 3 millimeters, 2 point.
It was about 3 millimeters because it was a multi-cut RK and it was 3 millimeters.
So difficult situation. I mean, because the knee of the measurements would be right there where the measurements are being taken. If you're using an optical biometer, I would still go with the optical biometer.
Right. I agree. So anyway, I think we should move on because we still have quite a few talks, and I think we are coming up with the keynote address. I request Dr. Mahipal sir to please introduce our keynote speaker for today. I'll just share the screen for a moment. Let me see if it comes up. I'm sorry. I think there's a. So I think Dr. Chi is our next speaker. Let me just share the screen. And there, one moment. I'm sorry. So I think Dr. Mahipal sir will not need slides for him to introduce our keynote speaker. Sir, please go ahead.
So actually, I think she should be given a nationality for India now. As I've often said, I think she's a wonderful person, and she's a professor at the SNEC. She's spread out as a junior, but in all the cataract now, she's the best, one of the best cataract surgeons on the planet Earth. So I have always learned from her scientific talks, has also seen her do live surgeries. I have also had the opportunity to do a live surgery in SNEC. And above all, what I wish to say is that she's always very welcome to India, and she has never refused an invitation, though at times she says that she's having too much of India, but I think she likes Indian food and Indian food, and she likes Indian ophthalmologist too. I think great to have you again with us, and I think nobody better to give a keynote address in this session of plaques. She's a pioneer. She's done several studies, and you can see that she has papers everywhere. So over to you, Professor Soufak. Our pleasure.
Thank you very much. Thank you for inviting me to participate in this wonderful webinar of yours. So I've been asked to share some of my settings. Okay, in fact, I think we can really debate about some of these settings. So these are my 2 cents worth. So my financial disclosures, and although we started out using the Victus, we are now using the the J&J system, like all of you. And I think dense cataracts are the most difficult, and you can see here I'm doing 8 segments, and what I want to show you here is these are my standard settings. All right, for a soft cataract, it doesn't really matter what you do, what kind of softening pattern. But for a hard cataract, like something like this, which is really, with no red reflex, I use my standard settings, all right, for any moderate to dense cataract. This would be the standard setting, 5 mm capsulotomy, incision treatment depth would be for the capsulotomy 600 microns. Horizontal spot spacing 5 microns, vertical would be 15. The pulse energy before, the maximum being 6, and then I like to use octants. I don't like to do softening pattern, although I did try it out initially because it produces too much gas, especially in Chinese nucleus, which tends to be very, very thick. We sometimes see over 6 mm thick nucleus. So I tend to just use octants, and just notice that I just use a single repetition for the cut. All right, so these are quite standard, and I use maximum energy. All right, you'll see I always use maximum anterior as well as posterior pulse energy, and the offset is 500 microns. So for this dense nucleus here, it was 13.6 seconds for the capsulotomy. Okay, now let's have a look and see, well, do you think the cuts will be good? Do you think will be clean? So this is a dense cataract in a Chinese patient, which is obviously going to be a thick nucleus. So sometimes I don't really want to put any more gas. I'm just worried. I don't know how much more this bag can take. I like to do a in situ chop. So that's a bit of a horizontal chop, but you will see straight away, I don't really seem to have that much difficulty. Right? Once I've embedded deeply, just separating those segments, and you can see maybe a fiber or 2 across, but actually it comes away pretty easily. All right, so in India, if you have got these very, very dense cataracts, I'm sure you all do, it can be quite difficult to cut, and sometimes we like to put in a lot of energy into this and several passes, but you will see that with this setting, that actually I received as an advice from, one of the scientists who actually helped to design the catalyst. Right, it was just a single pass with the maximum energy. All right, so give it your best shot, anterior, posterior energy 10 microjoules, and you'll see that you actually have pretty clean cuts. All right, at first I couldn't believe it, but you'll see that it's true. Okay, so these are really very, very clean cuts, and consistently you can get good outcomes with this. So we've talked about white and intumescent, and you can see this is an intumescent lens, and actually what I've done actually is decrease the vertical spot spacing from 15 to 10 microns, and then I increase the pulse energy, because very often the fibrotic bands that we may not even see on clinical examination. So I always stain, okay? Although I've gone through the main incision here, today I prefer to go through the side port when I start to do my staining, because sometimes when you lose too much of the anterior chamber, if you have an incomplete capsulotomy, it can run out. Okay, so very often it's not free floating, but because it's been reasonably cut, you'll be able to get a completely nice round capsulotomy. This is to show you a young patient, all right, and you'll see me actually adjusting. So I've increased actually the energy and decreased the vertical spot spacing, like what we did just now. But also for a young patient, whether it's white or not, I will decrease the capsulotomy size. And for a white cataract, I tend to decrease it nowadays, all right, because there's a tendency for it to expand after the capsulotomy, because it's actually put on stretch. So this is what I do today, all right? The rest of the settings are really no different. And I also do think it's worth doing the segmentation, and I don't do the general softening because this is a young patient. Generally for white cataracts, I do optants. And you may be surprised that in this case here, this patient is just in her early 40s. She had uveitis, and this is a complete capsulotomy. It was not really intumescent. For all these patients that are intumescent, I always run mannitol pre-op, right? And you'll see that this was actually cut, right? Not that it really needed to be softened and cut further, but definitely if you had a harder nucleus, even though it's white, it can be cut as long as it's not milky white, right? If there's any kind of tinge of brown also, you'll find that the catalyst actually does put the treatment through. Only time it doesn't cut is if you have a very thick area of fibrosis and that blocks the passage of the laser. It also blocks the OCT. Okay, so this is a hard posterior, not that hard, it's a relatively hard posterior polar cataract. Well, I didn't think that this was a problem with the posterior capsule. So I did what we call standard settings again. Optants for posterior polars, I always use optants. And I actually generally don't change the posterior offset. So it's exactly marked on the posterior capsule. As we talked about rings, well, no, there are no rings, it's just optants, all right? And I don't put in any fluid. As mentioned earlier by Kitensha, it's actually not predictable. I just put visco dissection in the subincisional areas here and do not rotate. Okay, I just crack this and just tumble out the fragments. And why do I not change the offset? I used to change the offset. And then I found that I'd have a big, thick, so I interrupt it, right? I just change the offset. Okay, now I'm going to show you the next one where I think there's a pre-existing complication, but I did not change the offset. So I think this was a bit of a mistake. So you just have a look here. Well, how do you tell whether that's true or not? I don't know. Okay, but this is the pre-op OCT which I did. And very often the true posterior polars look like this. Okay, and if you look at the cylinders, it's really strange because there's this round little area within an area of perhaps a mixed posterior subcapsular cataract. But this was moderately dense. And I did optants. I did not change the posterior safety margin, which I think perhaps I would if I think that there is a pre-existing break. All right, so I'm just going to show you the video now. Watch this big bubble here, right? I think that is a sign that it has gone to an area behind the posterior capsule. So no fluid has gone in, just a bit of visco dissection. Okay, so that's a superficial bubble. I'm troughing in this case to create a bit of space. You know, these polars are always harder than they look in terms of color. Okay, so I'm just cracking at the periphery, not over the center. I'm using the Phaco needle to provide the counterforce as I chop against it without rotating, so there was a cross chop. And now I'm going to tumble out the first piece, okay, without breaking the posterior plate contact with the posterior capsule. Now watch that bubble behind. Okay, can you see? It's strange, right? I kind of stop to look at it. Whoa, what's happening? Why is it not coming to the surface? Now it's come and I'm getting worried. I'm watching, look at this rip here. Okay, I'm sure it's actually already a pre-existing rip, but it's gone through. Okay, so now we can see this triangular appearance. Okay, I should have put in more viscoelastic, but it was fine. I didn't get ridges coming forwards. A bit of epinuclear plate, I decided I wanted to aspirate, although I think doing a dry aspiration might have been a better idea. Okay, so my parameters for vacuum, same, but the bottle height is lower now. And I'm doing it very slowly so that I don't engage any vitreous. I'm just stripping it out very, very slowly, making sure I don't break that vitreous face. And yes, I did get away. But you know, I think these pre-existing breaks always break into three. That's in my experience. All right. pieces. This comes to the sulcus and then an optic capture. And of course, that's the beauty of it. You have a nicely centered capsulotomy, and then you can do the optic capture because you have got that perfect sizing. All right. So I think that, you know, if you do suspect that there is a communication with the back, although it's difficult to tell just on the pre-op OCT and even in the intra-op OCT, which is less magnified, you know, I think I would want to increase the posterior offset, which is what I used to do before. And, you know, that sign of that bubble there, I think it just tells me that it's gone behind the posterior capsule. Okay, so this is lens subluxation. You can see microspherophakia. So we have to change the shape as we mentioned. Sometimes this catalyst OCT gets a bit confused because the shape is so different from the standard, and this is really small and it's very globular. All right, the zonules are present, although it's kind of weak there, and because this is a small lens, we have to reduce the size. I thought 4 mm was a reasonable size. At least my lens could get in. It was not a problem. Removing the lens is really a lens aspiration. It's just whether or not I can get my IOL in safely, and then we do the femto. And so let's have a look at this. All right, so I just want you to look at, of course we had scanned the capsular bag, but you know, adjusted down the capsulotomy. But you know, what I want you to look at is look at the capsulotomy. This seems to be reasonably cut. It tends to be very sticky in these lenses, but in this case, there were zonules all around, although they were pretty weak. All right, so I think this is easy. You don't really need to do any fragmentation, although it's rather pretty. It looks like a Christmas tree there in the center. I popped the whole thing into the anterior chamber, and then I aspirated this, and then I put in the capsular tension ring. And I think you know the rest of the story. 2 capsular tension segments with Gore-Tex. And I think probably I'll just skip this to the end so that you can just see the end result. And so 4 mm was a good size for this, but let me show you the next one. Right, so this is a traumatic subluxation, and there's actually vitreous. It's also a bit decentered, and it's also very intumescent, as you can see here. Okay, so we scan capsular bag, but I was planning to reconstruct the iris. You can see actually this traumatic mydriasis. And there were a few things that I didn't do that I felt that I should have done. So I had increased the capsulotomy opening to 5.2 because although this is intumescent, all right, I wanted it larger for the artificial iris, which should be at least about 5.5 mm. I didn't change the treatment depth, right? 600 microns, perhaps I should have. But one thing I should have changed was the pulse energy because there was vitreous. Okay, and actually I was a bit worried about this case, and I forgot to tell the technician who was helping me to actually increase the pulse energy. Vertical spot spacing actually should have also been reduced to 10 microns. So have a look at what we had here. You can see the vitreous here. So I started by doing vitrectomy from the front. I didn't dare to go by the back because it was intumescent, it was swollen from the OCT. So I decided, well, I had pigment there. I could just remove all that, you know, with the background. I wasn't sure triamcinolone was going to help me very much. I had blood, I had pigment, and you'll see actually no cut. Okay, there is an outline there that I can follow as a template for my size, and I went a little larger. Okay, so I think that, you know, when you have vitreous, you must definitely increase your energy, all right, and you want to increase that bandwidth of treatment as well. And this is just aspiration, and you can see, of course, Vision Blue went to the back and stained my vitreous and made my life rather difficult. But at least it could, you know, assure me of the correct capsulotomy size. I needed to stain not just because it was intumescent lens, but also because I want to be able to see the anterior capsule when I insert the artificial iris. Okay, so this is putting in the 2 capsular tension segments with Hoffman pockets and Gore-Tex. 7.0 Gore-Tex there, a bit more vitreous there. I'm cleaning it all out around the sutures so that I don't get it entangled. And then we center the IOL. And at this stage, I introduce the artificial iris into an injector. Medicell injector goes through a 2.8 mm incision, and then that goes into the capsular bag, having the vision blue stain. The capsule helps visualization, and then the case is done. But I learned some things that if you have a lens that is not very stable, I think during the treatment, that lens may actually be shifting during your treatment, and therefore the capsulotomy is not the only one. I've had a few where they don't really cut very well, even though you'd say that there's no milky cortex, there's nothing. In fact, I just did a pilot on Thursday, and again, it was just as bad as this. I didn't see anything. I just saw the imprint, right, as a template for me to tear, but it didn't cut, okay? And that patient also had a displaced lens and had some vitreous. So I learned that actually for these cases, really, we need to be putting everything to the maximum. So in conclusion, the catalyst femtocycline laser is an enabling technology. Complex cataract cases can be made less challenging, and trying the single pass for the nucleotomy. In fact, this is what I do as a routine, whether it's a hard or a soft cataract. It makes my time so much shorter. And most of the time, the treatment from the time you dock, put on the vacuum, to the completion of the treatment is only less than 1.5 minutes. And I generally do not do incisions, right? Optimizing your laser settings really enhances your ability to perform safe, stress-free surgery with ease. Thank you very much.
Thank you very much, Professor Chi. It's a fantastic talk as always. Just a question, though you have used all the platforms, so you said that Catalyst is preferable just now. As to what exactly, why do you feel that this platform is performed better in your hands as compared to others?
Okay, so for the Victus, what I liked was, real-time OCT, and that I could just see the treatment. But definitely the Catalyst would outdo the Victus in terms of speed, all right, for the capsulotomy and the where the nucleus is, and so that's all automated on the Catalyst compared to the Victus. We're actually doing it manually. The only thing about the Catalyst is that I wish that the OCT were able to penetrate better, because it's not swept source OCT, unlike the Victus. So for the Victus, I really can get wonderful views of the posterior capsule that can even image through a white on brown cataract. And once I diagnosed a ruptured posterior polar before I even did the femto, okay? Because when we looked at the swept source OCT, we could actually see that there was lens material already in the anterior vitreous face. So this actually gives me very precise capsulotomies. It's also able to scan the capsular bag, which no other system is able to do. So I think I really appreciate that, because I do a lot of work with subluxated cataracts.
Sir, I was thinking, Dr. Mahipal sir, today we are lucky to have 3 or 4 of our panelists, including Dr. Ramamurthy, yourself, Dr. Rohit Prakash, who have used multiple platforms like Dr. Chi, including myself as well. So, while all platforms essentially do the same thing and they're all very nice, but I have had a very pleasant experience in, having my going on from one platform to the next one in many of the ways. I always call it like the iPhone experience, where everything was done manually on my previous platform. I was using the Lensex before, which was also great. In fact, for incisions, I would think that the Lensex actually made slightly better incisions than I get on the Catalyst, but I don't care much for them. For my Rexis and for most of the other things, I love the Catalyst and, the user interface and the patient flows. For me, the patient flows are tremendous. Now if I have in a very busy OT about 6 or 7 cataracts, I will cut all of them on the Catalyst in about 45 to 50 minutes. And then, I will not get post-operative, intraoperative meiosis. With the Lensex, I would have this problem that if I wanted to do, I would split it into 2 parts, like 3 or 4 in one go, have meiosis sometimes, and then, I would struggle with that. And then, so I would be under stress in an OT when I was doing that. I have nothing to say against. In fact, Lensex has a lot of positives as well with cyclotorsion control. Ramamurthy sir, you have used both platforms. Where do you think one scores over the other, if at all?
Frankly, I'm quite comfortable with both of them. Both of them work quite well. It's, I think, just the economic reasons which makes you score one over the other. But otherwise, as far as the speed of cutting is concerned, this is definitely Catalyst is much better, especially the speed. It creates a Rexis just in 1 second. while it takes about 6 seconds with the Lensex. In Intumescent cataracts and organic cataracts, it's obviously a challenge. I think nucleus fragmentation is also something which is done better with the Catalyst platform. Incisions, as you mentioned, are somewhat better with the Lensex, but frankly, I've given up using the laser incisions at all. I believe that my incisions using a diamond blade or even a stainless steel blade works somewhat better. And I think both are quite good. One advantage of Lensex over Catalyst is the ability to integrate it with other, like the Varion, with the operating microscope. So while this works more like a standard, you can toggle from one area to another using a Centurion foot switch. And of course, that is an advantage, especially when you're using toric and drop lenses, etc. But otherwise, I'm very happy with the both the machines, and with Catalyst, of course, that's the one we use most often because economically it makes more sense.
So I think,
in fact, I also use, yes, Mahipal, I was going to ask you only because I also use the Virion for my rest of my things, but I think Catalyst does not really need me for the Virion. For the Lensex, the Virion was required because it would transfer the data. Otherwise, it was a pain to punch in all the data. It would take much more time. Here, I find that I can punch in the data in about 30 seconds, and it's like almost like the iPhone versus a clunky, user interface of the older versions. Mahipal, sir, and then after that, Rohit Prakash, sir.
So I think there are a reasonable number of examples of people having given up the Lensex. There are 4 of us. I think Ram has also shifted his Lensex to another center, I suppose. So there are 4 of us sitting out here, including you, me, and Rohit and Ram.
And Sonu Goyal, sir. I think Dr. Sonu Goyal as well.
Okay, so I forgot. So there are. So I think.
Are we selected in the panel because of that?
Yeah,
I don't know. It's coincidence, but
coincidence. No, but actually, if you look at it, I think one of the very important reasons is the economic reason also. And I think I haven't seen a reverse happening where a cat is replaced by a Lensex. But what you said, Gaurav, what Ram is talking about, Varion is something important. But I think I'll be talking about the new 6.0 platform that's going to be available in India in 2021. I think so. All those cases, all those things are being taken care of as regards the torsion, as regards also the mark for the Toric IOL, etc. So I think I'll just be talking about it. So I think they have moved reasonably fast on that. What you have said, Gaurav, is the speed and ease of doing it, and rightly so. I think there is no meiosis that is associated, or it's very minimal as compared to that, because the dock is the softest. And the cherry red spot, which used to happen when we started Lensex, obviously with the soft lens that is there, which has come in, the cherry red spots have gone down. But I think this is much more intuitive and much faster. Apart from the actual treatment time, that is one part of it, but actually reaching the treatment is much faster with a Catalyst. It's really a joy to work with it. The other important thing that is there in this system is that more often than not, we are able to bundle it with the consumables. So we don't have to pay a hefty amount of CMC, which in itself kills the viability of another system where you have to pay a lot of money for the CMC. There was a question that somebody posted on after your talk on RK, which was talking about whether you do an arcuate incision in post RK, and the other thing was that and the other thing was on the lens as to whether different base curves of lenses are used. So just to tell the person who has asked the question that in liquid optic interface there is no contact directly at all on the cornea, so you don't have to, because it's a scleral suction, so the curvature of the cornea does not matter. As to it's the size of the palpebral aperture which is going to matter, on which whether you use a cone which is of a bigger size or a smaller size. So since there is no applanation on the cornea, therefore you don't get any dimpling or any pressure points on the posterior cornea, which used to be a problem with the earlier systems, where you would get skip areas on the capsule. So Gaurav, the question for you regarding arcuate in RK.
So I would not want to do LRIs on RK at all. I've had, once when I did try to do that long back, I managed to get, a jet of fluid coming when I was trying to close my cornea because arcuate went through the arc incision. So definitely would avoid that, sir. I don't know if anybody else makes it.
The second important thing is that you can cut it and you can have perpendicular cut onto this thing, and you could have a gap. The other important thing is that the nomogram don't work for arcade incisions. So
and it'll be quite unpredictable as well, I think, because on archives, as you said, it won't work. I think, sir, we should ask Dr. Rohit here, who has used both platforms. And, you know, I remember him being a very reluctant second-time buyer. You know, I had to almost convince him that, you know, you're doing the right thing if you, you know, invest into a new. He was so disenchanted with his first experience that somehow he's not keen to go for a second time. And let's hear whether he likes his new purchase or not.
I think there's a sea of difference between Femto 1 experience and the Femto 2 experience, as I've said. And I still remember Dr. Mahipal talking some time back that your time for the surgery decreases. The ease increases. Well, how true he is, because it was there the same in the first 50, 60 cases. And now, you know, it's a pleasure to do, you know, with the plaques. The capsulotomy is there 100% of the times, 99.68, whatever you want to say, but I'm not giving incisions for that matter. Somehow I feel, you know, that, you know, when the patients ask, we always tell them that we are not making it rate-free. That's what we are doing. So because, you know, it's maybe we have some way to go as far as incisions are concerned. The fragmentation, softening in harder cataracts is there to be seen. You know, your endothelial cell count, you know, that is much better with the flax than with anything else. So, and the softening has also helped a lot. Yeah.
Kumar, you wanted to say something? Yeah.
I wanted to ask Professor Chi, I saw your first case was extremely hard cataract. Now, any particular reason besides time that you don't prefer to do cubes for softening it and you only do octane? I saw that your octane separation was very clean. I normally have a higher repetition rate to get that clean cut, and I've realized that it may not be necessary. But why would you not prefer to do softening of the nucleus, and that would really reduce your phaco energy and phaco time?
Okay, so you've asked a very relevant question. Well, you know, I did a few cases with like, you know, 5 repetitions or more even. And I did all the grids because, you know, to me, it made a lot of sense to do softening in the hard cataract. But as I mentioned, that our nucleus can be so thick, over 6 mm, which means I'm doing probably 1.5 times the work that you do in the Indian cataract, right? So there was so much gas production that that particular patient gave me such a bad experience that that lens, that nucleus actually tipped out of the bag on its own before I even entered the eye and ripped the anterior capsule. Okay, because there's so much gas. And in fact, I did not even manage to complete the treatment because to complete the nucleotomy, it was something estimated to be like 4 minutes. Okay, and I just watched that video again today, all right? And, you know, after that, I went to J&J and I said, look, this is terrible because most of our cataracts that we, you know, wish to use the catalyst on are like this. They're so thick, they're so hard, and, you know, I can't use the softening pattern. What can I do? That means I can't use the catalyst safely on the cases that are most indicated for flax. And then, you know, they brought me to speak to the researchers, the R&Ds and so on. And actually, Georg is the person who actually was one of the initial engineers who invented this laser. And he said, this is what he recommended. He said, go back and try. And I was rather resistant for a few cases. And then I was just, you know, not making any headway. So I said, all right, let's give it a try. And I was so pleasantly surprised. It cut so cleanly. So, you know, whilst we are speaking about reducing the energy and minimizing the endothelial cell loss, I'm preparing the manuscript now of our randomized, prospective randomized study for hard cataracts. And this is actually using that was actually using the Victor system, all right? I was surprised that actually there was no difference, all right, in the amount of energy used if I had actually segmented it just radially? Because I thought, well, if I done radial segmentation, that, you know, it was so easy, as you saw, the pieces just came apart, that I would be actually doing surgery faster, I would be actually saving on endothelium. I was surprised there was no difference. In fact, in the Victor study that I was doing, it was dividing into 16 segments, which made even, you know, separating the pieces, and Victor also cut very well. It really made no difference, and I was surprised. What made a difference was actually doing grid. All right, so you're right. Actually, it does make sense, but it needs to be in a setting that is safe. So if your nucleus is not that thick, then I'm sure it would be safe for you to do, you know, a grid pattern. But I would still think single pass would be adequate. Otherwise, you take so long and you have so much gas production.
Thank you very much. I think, Kumar, there's a point that if you have a lot of softening, the hold that you get on the piece becomes, because it just pulls away. So if you want a better hold, then you don't want the softening in these small cubes that you have. Yeah, Gaurav, we can go ahead.
So should we go on? Yeah, we are behind schedule. I'll take this opportunity to introduce our next speaker. And that's none other than past president of our IIRSI, past chairman scientific committee of our IIRSI, and my dear friend from Coimbatore, chairman of the Eye Foundation, Dr. D. Ramamurthy, who has been, you know, a great guide for me as well. And you know, he has really changed as during his tenure as scientific committee chairman. He really brought about a lot of radical changes in the scientific committee, which have done well for the IIRSI. And he's a prolific surgeon, cataract and refractive. And I'll request Dr. Ramamurthy sir to please go ahead and share his wisdom. Now he's going to tell us about how he uses the Femto platform to have happy 20/20 patients, you know, which would include several things, including astigmatism correction, which can be done on the Femto platform, and a lot of other things. So go, request sir to speak.
Thank you so much, Gaurav, for this nice introduction, very kind introduction. I think a wonderful presentation so far. I hope I'm able to keep up the tempo. Obviously, both in the medical parlance as well as in the lay mind, laser is synonymous with perfection. So it's but natural that because of its increased predictability, reproducibility, and safety, we use it in the most commonly performed surgery in the human body, that of cataract surgery. And I think more and more we'll be using this as we go along. It's not just the availability of the femtosecond laser, but also the fact that the entire process is image guided. That makes me the surgery so much more attractive. This must be a very familiar slide for all of you. Capsulotomy, reducing the phaco power, making incisions, and handling corneal astigmatism are the advantages of this system. I'm going to be dealing with corneal astigmatism, which I feel is one of the aspects which is not much talked about when we talk about the laser platform, though we're constantly doing it. And I'm going to take a deep dive into it and see how we can optimize the laser arcuate keratotomies that we deal with. Most of us are aware that 25% of our patients have more than 1.5 diopters of astigmatism, and obviously these are cases where we want a toric intraocular lenses. But then there are almost 70% of our cataract patients who also have significant astigmatism in the range of about 0.5 to 1 diopter. And these patients are not amenable to a toric intraocular lens. That's the reason maybe that in Australia, the usage of toric intraocular lenses, where it's entirely subsidized by the government, is almost 70 to 80%. Obviously, in our conditions, that may not be possible. And this is exactly the segment which I feel would significantly benefit from the laser arcuate keratotomies, because once you deal with it, whether you're using a monofocal or a multifocal intraocular lens, the unaided visual acuity as well as the image quality is going to significantly improve. So as far as the basic information that we need to feed into the machine, most often we are discussing about toric intraocular lenses, the kind of formula that needs to be used, the kind of refinement that has taken place. Some of these limb relaxing incisions and laser arcuate keratotomies have not attracted that kind of attention. As was mentioned earlier by Maipal also, right through Asia Pac region, we have the version 5.0, and this does not have any in the catalyst, and this does not have a nomogram incorporated in it. And once the version 6 comes up, maybe we would have the benefit of using a nomogram that's inbuilt into the machine. One of the popular nomograms is to use the Donenfeld LRI nomogram, which is essentially meant for incisions at 11 millimeters. So when we are making our cuts at 8 or 9 millimeters, we reduce the arc length by about 33%. While the Julian-Stevens nomogram, which was essentially meant for intrastomal arcuates, where you leave about 20% of the corneal tissue uncut, is something I do not use simply because I do not believe in that intrastomal arcuates help. I always open up my arcuates. What I use normally is the Varion, which is guided by the Holiday, and this is essentially meant for the penetrating laser arcuates. So the Varion gets the measurement, tells me where exactly to position my incisions as well as the arc length of these incisions. That's something I use on my catalyst. It's a marriage of two different modalities, but it obviously works well in my hand. Just as a matter of guidance, usually you require about 22 degrees paired arcuates at 9 millimeter for correcting about 1 diopter of cylinder. And when you go to about LRI for about 11 millimeters, you require about 30 degrees. So usually it's 1/3. That's the difference between these two. And but obviously it's better to be precise in your calculations. This is the kind of measurements that I have. I'm going to be dealing only with arcuates. Even for just about a 0.5 diopters, you can see that's a paired incision that I use, 32 degrees and 112. It's a 9 millimeter, and it's a good, if you want better effect, you can even go down to 8 millimeters. And let us go on to the video. And this is essentially the docking that is taking place. And I would like to, because I think it's extremely important for us to understand that we are going about 80% of the depth. If it's a 500 micron cornea, we go almost up to 400 microns is the depth of the incision that we make. When we talk about a capsulorhexis, it's about 300 microns offset. But here it's extremely close to the endothelium. In case the patient moves his eye or the docking is improper, there's always a chance, though we rarely ever seen it. I've just had one case so far where it could go right through and create a through and through incision. So essentially, when you are looking at your docking, it's important that you make sure there's a free area over there. And if you're looking at a penetrating incision, make sure that your incision is coming out. And let's move on. And basically, it's nothing much. It's capsulorhexis followed by nucleus fragmentation, which will just pass forward. In this case, it was just about a doctor of astigmatism that I was trying to deal with. That means about a 22 degrees of paired arcuate incisions. And it just takes about 2 seconds to complete this. I usually do not use the laser platform to create my side port incision. This is what you see under the microscope. The point I want to make is that even if I am seated temporally, even if it's the astigmatism is against the rule, which is most often the case, I go ahead and use the arcuates. And I feel that it does not interfere with my blade-created incisions, which I'm careful to ensure that it does not interfere the arcuate keratotomies. And that's this is the beginning of the surgery, but we'll quickly pass on to the end of the surgery. Gently hydrate the primary incision. Make sure that the globe is quite well inflated. Then open up these incisions quite adequately. I believe that unless you open up these incisions adequately, and actually you can see the scratch marks, the patients complain of a little bit of discomfort and irritation in the immediate post-operative day, even overnight, but I think it's worth it because that's when these arcuates actually work. And this is at the end of the surgery. And just in case I have arcuates with the rule astigmatism at 90 degrees, I go ahead and open these incisions up right in the beginning, even before I make my primary incision, because a well-inflated globe, this when the incisions is extremely easy to open. So it's essentially going into the depth of the incision up to about 80%, and opening these up is important. And I find that that's when these actually work. So it's not just the magnitude of astigmatism that you deal with, as is our experience with the toric intraocular lenses. It's also the axis which is important. You can see over here a 0.81 diopter of cylinder, but it's with the rule astigmatism. What my machine suggests is no arcs are necessary. Obviously, there is no arcuate incision that's incorporated in this. On the other hand, you see a situation like this, where you find that it's just a 0.5 diopter of cylinder, but 174 is the steep axis. Obviously, with about a 0.5 diopters of against the rule astigmatism, the posterior cornea, you have almost 1 diopter of against the rule astigmatism. Here, it's a good idea to go ahead and place a pad arcuate incision, which would deal with almost a diopter of incision, diopter of astigmatism. So just like you would concentrate on the not just the magnitude of astigmatism, but also the axis of astigmatism when you are implanting toric intraocular lenses, I think that should come into our minds when you are using the toric, when the arcuate incisions also. And whenever I'm using a multifocal intraocular lenses, trifocal intraocular lenses, etc., or the symphony lenses, it's extremely important that you reduce the amount of astigmatism that's left behind postoperatively. And again, you can see that it's against the rule astigmatism, 0-180 degrees incision that have been created. I find that debulking the astigmatism using this technology, whenever the astigmatism is less than 0.75 or 1 diopter, is a great way to go. And this is the pad incision that you see on the first postoperative day. And usually these are quite effective. I essentially was using a fair amount of limbal relaxing incisions. Gave that up because they were inaccurate, used to regress. But now that we have an image-guided technology, we have extreme control over the length and positioning of these incisions. The depth of these incisions is tailor-made depending upon the corneal thickness that's measured by the OCT on the table. And usually I leave behind up to about 20% uncut. Though there is you can leave up to about 50% uncut in the posteriorly, but this would not be effective. You leave just about 20% uncut. And it's also said that these incisions are titratable, that depending upon the astigmatism that the patient is left behind with, postoperatively, maybe a couple of days later, or even a week later, you can open them up on the slit lamp. I hardly ever tried that because what I get with these incisions under correction, and I believe that it's better to open it up on the table. And it's also important that we place the incision exactly where it is meant to be. And just like with our toric intraocular lenses, once there is these incisions not placed on the right axis, there's a loss in the effect that you get. With a 5-degree misalignment, you get about 1.5% loss. With a 50-degree misalignment, you get a 50% loss. But with a 30% misalignment, you get a 50% loss. With a 45-degree misalignment, you get almost 100% loss. So extremely important we align this exactly. Maybe the version 6 will allow us to do that. If I had my Varion linked to my Lensex, that's a possibility. But obviously, there are several other advantages to technology. I'm not going to go into the literature that is available, but a latest article by our own Ashok Grover, published in the 2020 Indian Journal of Ophthalmology, tells about the significant reduction of astigmatism that he was able to achieve. This is preoperative, the mean preoperative astigmatism, the vector corrected values, and the postoperative astigmatism. We ourselves are conducting a study. It's a thesis for one of our postgraduate students studying the Varion guided astigmatism correction on that on our this present platform, the J&J platform, and it's working out quite well. Our initial results are quite encouraging. The 1-year results are awaited. I think maybe the next time I talk to you, I'll be able to share the results with you. I think we have had multiple excellent presentations on the difficult scenario, but most often we are faced with patients who have simple cataracts and their expectations are extremely high. And 95% of our cataracts belong to that category. The ability to deal with small amounts of astigmatism, which obviously translates into better visual outcomes in these patients, is a great benefit as far as laser cataract surgery is concerned. Thank you so much for your attention.
Thanks, Dr. Ramamurthy, sir, for that wonderful presentation as expected. And, you know, I see that Dr. Sharad Babu, who has been using the femtosecond laser for about a few 6-8 months, and he's new to the platform. And it would be great to have his views on what change he sees in his refractive results and how he uses the femtosecond platform to get better visual outcomes for his patients. Dr. Sharad?
Yeah, up to 1 diopter of astigmatism, I'm using this platform. But then I am using the same normograms which have been used by everyone. And of course, I'm getting good results with them. And more than one after, I'm using the Toric IOLs. So,
absolutely. Dr. Maipal, sir, can you take it forward?
Yeah, let's go on to the next speaker, I think, in the interest of...
One question.
Sure. Yes.
So what are your long-term results of, astigmatic correction laser?
Actually, as I mentioned, Rohit, I mean, we are presently analyzing it in a prospective study, in the sense that, we have done on 100 eyes between 2018 to 2019. We are going to analyze that. The initial results seem to be quite encouraging. Definitely, it's not as accurate as a laser vision correction. It's essentially debulking of the amount of astigmatism that the patient has to deal with post-operatively. Usually what I find is that if you initially have about 0.75 to 1 diopter of astigmatism, the patient is left behind with about 0.25 to 0.3. And over the long term, whether it regresses over time, like you see with limber relaxing incision, that's something that remains to be seen. But at least the initial results, especially with multifocal intraocular lenses, is quite good. And both as far as the quality of vision and the quantity of vision is concerned.
I think I completely agree with Dr. Ramamurthy, sir, that I find that with my multifocal lenses, any astigmatism below 1 up to 1 diopter, I find it to be a great tool to have better and better results and happier patients. Otherwise, we were always in a dilemma whether to put a toric and when you didn't have a toric. So I think, thanks, Ramamurthy, sir, you have absolutely echoed my thoughts and covered the subjects really well. And we will come back to a discussion on this after a couple of talks are over. I'll invite our next speaker, my dear friend, Dr. Cyrus Mehta, prolific surgeon from Mumbai, a biker. And, you can see that on his background, which you'll shortly see. He's on the Formula 1 track many of the times. And yes, he does Formula 1 stuff on his in his OT as well, tackling difficult, cataracts. So he's going to tell us about how he manages this for very difficult cases, which are the subluxated cases. And Femto does have a great value to subluxated cases as well.
It's great to be here today, and thanks very much, Gaurav, for having me, and Maipal sir. And so my topic today is no option to flax and sublux lenses. So basically, the whole point is that do you want a perfect rhexis every time? So you have to remember this, that machine never gets tired and rhexis is always perfect. Let's have a look at this very simple video to illustrate this point. So when the laser system was first launched, everyone said that the capsular rhexis will be weak. And this was a common problem that everybody felt capsular rhexis will be weak. And if we have to position the capsular bag and it won't take the stress of capsular hooks. So we chose this case to demonstrate. So we line up, this is a 10-year-old girl with a sublux lens. So I wanted a 4mm capsular rhexis. So we put in 4. But it's intersecting with the iris. So we modified a little bit. And the largest that we can get is about 3.5 because I wanted a perfectly centered rhexis. The lens is tilted and there's a huge amount of subluxation. So with a femtosecond laser, you will get a perfect rhexis like this, which is otherwise impossible by hand. This is a huge amount of subluxation and the lens is tilted as well. Use sodium hyaluronate, create some space, and then use capsule hooks to hold the capsular bag. Once you position the capsule hooks, you can see that the femtorhexis is quite tough. There's no problem there. You don't need any fragmentation in a 10-year-old. And now this is called a Gupta segment made by Madhu in Delhi. And we use a tenoproline, and this is a suture with 2 arms. So we can't railroad it out until you don't remove the hooks because there's no space to do it. So now we railroad out 1 suture and then we railroad out the second one about 3 millimeters apart. So now you've got the ring segment, which is stabilized by two separate arms of the suture. So now we have to get the ring segment into the eye, which is very simple and straightforward. So put the ring segment inside. Now it takes a lot of juggling because it's a large ring segment. It takes a lot of manipulation to push it into the rhexis. So you have to inflate that bag properly and then get the ring segment in. And then you can pull on the suture, tighten it, and fasten the capsular bag. And then also use a tension ring like this to stabilize the bag. Next step is to pop in the lens. So even though it's a 3.5 millimeter rhexis, because of the ring, etc., it stretches, and you can get the lens into the capsular bag. So that's how the case ended. So this demonstrates that yes, femtosecond laser rhexis is as good as a manual rhexis. It's no weaker. If it can take this much stress and strain, it's pretty good. This was the end of the case. So Gaurav said, please produce a quick 5-minute talk, and here it is. So finally, there is no better option to flax and sublux lenses. This is the prime, the whole point of having the system. Yeah, if you have a small pupil, you can still do phaco, and if you have a hard cataract, you can still do phaco. But in a completely sublux lens like this, when you're relying on a perfect capsular rhexis, there is no option to flax.
Thanks, Iris. In fact, I completely agree that it's a great option if you have a perfect rhexis in a sublux cataract. But here I would like to ask our panelists if anybody would like to chip in. Dr. Chi is the master of sublux lenses. That is there a situation where in sublux cataracts, because the lens is tilted and sometimes you may have an incomplete rhexis, and at some points you may not get a complete rhexis as well. So any pearls for that, and anything that you would like to share there? It's not as easy as it looks. The settings need to be good.
I think that the only problem is if that lens is really too deep inside the eye or too tilted that you can't really get a good capsulotomy. Because that sometimes we don't dot the eye perfectly and that lens is tilted, we still get a reasonably good cut. So I would actually try, because I think even if you had part of a capsulotomy, it would still be half the work done, because we struggle a lot over these capsulotomies trying to get them perfect. And having it done halfway through, I'll be happier. Yeah.
And what about the size? Like, sometimes you'll end up having a much, because you have to move it eccentric. So what would be the minimum size that you would be happy with?
Well, it really depends on the lens bag. Like what I showed the microspherophakia, it was really quite a small lens bag. So relative to that, that's 4 mm, but that's what I also created. And once you stretch it, when you put in the CTR, you stretch it, that would also stretch. So I think it's very difficult to estimate size. For example, when you do a patient with Marfan's and you do it manually, you create a oval rhexis, and when you put in a CTR, it becomes round. So it really depends on what's the original shape. It's really quite difficult to predict. So I'm not sure if you have a ovalish lens because it's partly deformed from lack of zonules in a Marfan's patient, and you do a round capsulotomy, and when you stretch it, it probably becomes oval. Yeah, so I think it's quite difficult to predict. As long as you have a reasonable size relative to the lens size that you're working with, and that you can see, when you project what your plan for the capsulotomy is at the time when you're planning after you have actually docked the eye, you can actually decide whether that looks reasonably in proportion to the size of the lens that you're working with. So I don't really have like a minimum size, because that tends to stretch when you're dealing with small lenses.
Right. Mahibal sir, any other things that you would like to discuss? Otherwise, we'll invite our next speaker.
Yeah, I think we can move on to the next speaker, but I think subluxated lenses and all the flexibility that the Catalyst system gives in being able to customize your capsular rhexis is important. And when you go on to the manual mode, you actually get the infrared visualization where you can actually see the border of the pupil so that you're not intersecting it. So I think it's a great platform to work on subluxated lenses. I think we can move on to the next.
Sure, sir. Sir, would you like to invite our next speaker? Dr. Namrata has just joined and she is our next speaker. So I'll request you to introduce our next speaker, although she needs no introduction, but here goes.
Yeah, so it's my pleasure to invite Dr. Namrata, Professor Namrata, who's the Honorary Secretary General of AIOS, DOS, and also a great cornea surgeon. She's doing a great job, I will say, and as somebody put it, as she's the Iron Lady of AIOS. So I think she's going to talk about working with the compromised corneas. So over to you, Dr. Namrata.
Thank you so much, sir. And nothing in AIOS would have happened without your guidance and your vision. And I think all of us on the panel are in affirmative on that. We've all witnessed it, whether it was trade or whether it was guidelines or whether it is, anything and everything. I would be talking to you about femto cataract surgery in the presence of corneal haze, and it helps in all the steps, including the incisions, the capsular rexes, even nucleotomies, and even in intraocular lens implantation. So one in these cases is you have to plan your location. So the setting of the incisions doesn't change, but the location of the incisions may change depending upon the corneal haze. Then settings for the creating the location remains unchanged. We may have to defer or relocate these incisions if it is not possible to put it. And sometimes because of the corneal pathology, it may not be possible to, even when you make the cuts, you may still need the blades to do it. Likewise, for capsular rexes, one has to plan to encompass the haze, or it allows you to do eccentric capsular rexes also. And underneath the haze, there may be uncut bridges which need to be relocated and cut. And for capsular rexes particularly, we do increase the energy on a Lensex platform for capsular rexes from 7 to 10 millijoules. Now, there are various patterns which are available. This is, of course, not in the haze, like spokes such as this. Then you can have fragments and 8 spokes, and I think this is the pattern, the first one, which works the best in these cases. Then you may have to do, you can do 3 chops, and then there can be a hybrid pattern also, 3 chops plus 2 cylinders. So just to show you some of the cases, this is a case of corneal haze again, in which the planning is being done. And the astigmatic keratotomies are also planned, although I do realize that it's not a very good idea to do it in the presence of a little bit of corneal haze. What actually happens is that the capsular rexes is made in the area of the haze. It may not be complete. The chops are made again in the area of the haze. They may not be again complete, but in this case, because the haze was present temporarily, as can be seen here, so it did help in the making of the chops as well as making of the rexes. And we were able to open up the incisions as well, and this particular incision is being opened up, and this did not open up and finally had to be made with the side port. Stain the part of the capsule because it always helps in the presence of the haze. And wherever it is uncut, we can just cut the bridges, and we can do it with the help of the forceps, capsular rexes forceps or Trata forceps, or with the help of the micro forceps. This can be done. In this case, it was complete. And when those spokes are there, or those cuts have already been made, the amount of phaco energy that you use is far less. And because these spokes are already made beforehand, so even if you cannot see them underneath the haze, you don't have to make them with the help of the chopper, but the cuts which have been made before only have to be deepened, and the case can be then done completely. And this, of course, again can be done with the help of bimanual irrigation aspiration, but since I use coaxial more than bimanual, this can be easily done through that. And this case actually femto was done and then was taken under intraop OCT microscope, and irrigation aspiration was done. And notice that the capsule is crinky here, and sometimes the capsule becomes taut, and essentially depends on the size of the IOL as well as the bag. Now, this is yet another case in which the capsular rexes was not quite complete. So the bridges had to be, again, it had to be bridged with the help of the forceps. And here the haze is quite central. The pupil also came down during the course of the case. And again, if those chops have been made, all you need to do is just separate them. And it is a lot safer if they've been made before rather than you having to make it. And this is yet another third case, again with the corneal haze. where the femtosecond helps to do the steps to do the steps such as capsular excess again. And notice in this case the haze is quite a bit, and you can also see a vessel along with it. And in this case again, at this area, the capsule was a little incomplete, which had to be completed. Eccentric rexes can also be done, and the pupil came down, so the chops had to be done with the pupil which was small, followed by a foldable intraocular lens implantation. So it does help, and it also helps to reduce the phaco energy in these cases. So it is possible to do it in the presence of corneal haze, helps to fill in the gaps or fill in the blanks, whether the gaps are there in the capsular rexes or in the nucleotomies, and it softens the nucleus, so you use a less amount of phaco energy, and it does give optimal outcome in these cases. So thank you very much for your kind attention.
Thank you very much, Dr. Namrata, for an excellent presentation. And I think as these gadgets come on, they will be finding more and more use in all these cases. So there was a question earlier which was talking about contraindications for femto laser, and I think dense corneal opacity would be one of the major contraindications where you will not be able to do. But how do you kind of titrate if there is just a nebular corneal opacity, or what? How would you kind of practically change your settings or placements and things like that? When would you regard an opacity, or when would you be concerned about the opacity?
So if the opacity for the capsular, you have to increase your settings because otherwise it will not happen. And as far as the nucleus offset is concerned, that would depend upon the grade of the cataract. And as far as the opacity is concerned, if it is a nebular haze, you can still do it. And you can also do it if it is a leucomatous corneal opacity, but it is localized. But if it is a opacity which is encompassing the whole of the cornea and it is leucomatous, then of course you can't do it. So one good way would be to look at the retroillumination, which may be possible in some of these cases. So this is to say that you can do it. It is doable. And I think we've all seen this in RK cases also. One can do it without any problem. You don't have any problem even in those cases. I wanted to see whether we can do it in such cases of nebulomacular haze and in leucomatous corneal opacities which are paracentral or not entirely in the center. Even if they are there, if the haze is there in the center, you can still plan the size of the rexes in such a way that it can go a little larger than the area of the haze so that it cuts there.
I had a question, there was one study which claimed that endothelial counts would be, specifically compromised, especially if you were making corneal incisions. So, at AIMS, have you seen, would you still be okay to do like on a Fuchs case or on somebody with compromised endotheliums? Would you be okay to do, and would you avoid making corneal incisions specifically or anything else?
No, specifically for Fuchs cases, we wouldn't do this. We would probably do it only for cases of such as, healed keratitis, or where you know that the endothelium is not diffusely compromised all over. So you wouldn't do for those kind of...
No, but is it like, would you avoid the corneal incisions only, or would you also avoid the rexis and nucleotomy in patients with compromised endothelium?
In those cases, you can avoid corneal incisions and still go ahead with...
The rest you can still do, right? I mean, there was one study presented in APSARS, and I think Dr. Chi is aware of that where they presented about, they did a study of comparing, energy, especially with those incisions, with those nucleotomy things where there's a thick nucleus and a lot of energy is used, that they had endothelial compromises. Dr. Chi, would you change anything in compromised corneas?
Well, generally, I don't like to do incisions because that can, actually has been shown, I think it's Brendan Boat's group that actually showed that the endothelial cell count actually around the area of the incision actually dropped. But at 6 months, it had, come back to normal. But
so there was this film in the film festival at the APSRS, which I remember discussing with you as well, about not yes. about the corneal incisions, but about the energies used in nucleotomy, where they found that they noticed endothelial cell drops with energies where a lot of multi-cuts and multiple repetitions and a lot of energy was used in the nucleus. So that was one concern as well. But I haven't seen anything, and I don't think amongst our panel anybody might have noticed anything like that.
In Fuchs.
I think that is a preference in Fuchs because you get a great capsulotomy and you get a good nucleotomy. So that has been universally shown that the amount of phaco energy that you're using once it has been, nucleus has been taken care of by Femto is reduced significantly. But I don't do the incisions, that's for sure.
Thanks a lot, sir. Thanks, Dr. Chi. Yes, Kumar, you want to say a last word before we move on?
Talk as usual. I just wanted to ask you, you have everything very premium, so there's nothing remaining that you don't have. So if you have a corneal opacity, a leukomatous corneal opacity, and your rhexis is not complete in that area, with the online OCT, you can actually make out that the rhexis is not complete, or you can't make out that?
No, you can't make out, because on that particular area, it's going to be, you can't see under that part.
So that's
What you can make out with the online OCT is if you just manipulate the globe a little bit, you put the globe down or put the globe up depending upon the opacity, then you can see the edge of the folded rhexis there like that. So if you've lost your rhexis underneath the haze, then you can relocate it by, manipulating the globe right side, left side, or, from the area that you can see. But just bang on the haze, you will not be able to see.
Thanks, Dr. Namrata. Now I'll request Dr. Maipal sir to invite our next speaker, who's again another one of his, stalwarts from IIRSI. And I'll request you to invite Dr. Sonu Goyal, who is going to speak on Intumescent cataracts. Maipal sir?
Yeah, thank you very much. Pleasure to introduce Dr. Sonu, who's really done wonders, starting with the cataract surgery, and also is a pioneer in Femto. And he's actually the director of Ananda Hospital, and he's a member of the scientific committee of IIRSI. He's also been, he's I think presently the chairman scientific committee of the Rajasthan Ophthalmic Society also. A keen academician, and above all, I think a very nice human being, as also a great surgeon. So over to you, Sonu, all yours.
Thank you, Mahipal sir, for that wonderful introduction. That was very kind of you. And I would like to thank Gaurav for making me part of this wonderful program. And my regards to Professor Chi, Dr. Namrata, and all the panelists and speakers. Laser cataract surgery in intumescent white cataracts. Gaurav, I believe I'm audible and my slides are perfect?
Yes, Sonu, very much. Thanks. Yeah.
So that's my preferred technique. So we all know ultrasonographically, the white cataracts can be classified into 3 grades: type 1, type 2, and type 3. Type 1 is usually an intumescent cataract, a white cataract with cortex liquefaction and high internal acoustic reflections. It's where the Femto works very well. The type 2, the white cataracts with voluminous nuclei, little amount of whitish solid cortex, and low internal acoustic reflections. Again, you can get a very good capsulotomy here. And at times, you can aim for softening, as very nicely highlighted by Professor Chi. And the type 3 usually is white cataracts with fibrosed anterior capsule and low internal echo spikes. Now, it is here where the Femto becomes slightly challenging, because getting a rhexis in these fibrosed anterior capsule becomes a little tricky. So the main challenge in phacoemulsification in white cataracts is achieving a continuous curvilinear capsular rhexis. Why? Because there is an absence of a red reflex, there is a high intralenticular pressure, and most of the times we are dealing with a fragile anterior capsule. An ideal capsular rhexis for me would be one which is very well centered. It is a circular opening, a smooth margin, and has a 360-degree IOL coverage, a wrap all around the IOL. So when you're dealing with premium IOL, you have a very well-centered lens in the bag. And inadequate coverage of IOL, we all know, would lead to an early posterior capsular opacification and definitely a change in the effective lens position. And most of these mature cataracts, when we are dealing with, we end up doing a very small rhexis, which may at times cause an anterior capsular contraction and maybe a cause of an early lens subluxation. A wonderful paper by Professor Namrata and Dr. Tial, where they compared the evaluation of the femtosecond laser-assisted cataract surgery and conventional phacoemulsification in white cataracts. Another paper is laser-assisted capsulotomy better than the standard CCE by Monica. So they all concluded that the femtosecond laser-assisted capsular rhexis most of the times is round, it's well-centered, and usually you achieve a desired size of the capsular rhexis. Now, these all points are very important when you're dealing with a premium lens like a toric or a multifocal or a trifocal lenses. You calculate the power using the best of the formulas, the best of the IOL masters, and the machines. Putting the lens right in the bag, right in the center, is what is required when you're dealing with these premium patients. The manual capsular X most of the times is based on the surgeon's skill and the experience, and it requires a good local anesthesia. You have to stain large quantity of cohesive viscoelastic. It has to be used, and definitely most of the times you have to have those micro incision forceps. But beyond that, the size and the centering of the capsular X's are not always identical with the intended ones. So I had the experience of using both the Lensex and the Catalyst, but the Catalyst edges giving me highly accurate capsulotomies, powerful fragmentations. So here, most of these patients, and specifically in this COVID era, we're getting these mature cataracts. Carefully, if you see high intralenticular pressures, you can see the fluid pockets beneath. And what is most important is achieving a round rexis, which is well centered and of the desired size. This is what is aimed at. You can have patients with high intralenticular pressures, with fibrosed anterior capsules, and you can, most of the times in the slit lamp, you can note that the capsule looks quite thickened, fibrosed, the lens is hard, and you have the fluid pocket sitting inside. So taking these patients on a routine phaco emulsification, despite using a good viscoelastic, most of the times we end up creating an Argentinian flex sign. So to achieve 99% 360-degree capsulotomy, a capsulotomy which is stronger than a manual, predictive size, I address these patients using the Catalyst laser system with a pulse energy varying between 4 to 4.5, incision depth of around 500 microns. I switch off the lens frag, and yes, with the live OCT, you can make out, if you carefully see, the fluid pockets beneath the anterior capsule. Now, less than a second, if the time is, I don't think you'll ever have the radial tags or the anterior capsular tears. I push in the viscoelastic and always stain these white underneath the viscoelastic because it gives me a very uniform staining of the anterior lens capsule. Usually, I would do a dimple down with all the cataracts, but specifically in these white cataracts, I would go 360-degree, making it very, very sure that I don't have a silver tag or an attached area which would extend and give me an anterior capsular or a radial tear. So I would just very carefully move all 360 degrees, try to ensure that I have a 360-degree free-floating capsulotomy which is separated. Now, once this is done, most of the job is complete. The frag can be done. And yes, in young patients, the segmentation can also be taken up, and the laser usually penetrates to a certain extent where you can easily fracture and eat away the lens frags. So addressing the premium IOLs with this makes your life very easy because you have a lens which is very well centered and with a 360-degree overlap of the rexes in these premium patients. So once this is done, the lens is a symphony lens here. So whether it's a multifocal or a trifocal or an EDOF lenses or a trifocal lenses, I think the ELP is the thing to be taken into consideration. So the lens goes in a very well centered rexis and a centered lens looking into the 3 Purkinje images, the Lumera. I centered these lenses, and yes, day one, you have a pristine cornea with a lens sitting right there in the center. So the basic advantages is a highly precise capsulotomy in terms of sizing, the shape, the centration, the pattern, and the architecture. It's more predictable, and this prediction gives you an increased precision and a good refractive outcome, less dependence on the surgeon, and the safety and ease of the surgery. It's moreover performed in a closed chamber and a no-touch machine-driven technique, and a better IOL centration with a 0.5 overlap, less chances of the IOL tilt, and a more predictable ELP. There are certain downsides with this. You can have silver tags and you can have radial tears and anterior capsule tears. So you have to be very, very careful when you're dealing this. And we already had a discussion of making it less than the time should be less. And you should be very, very careful when you're dealing, because the fluid egress can at times leave areas which are uncut. Thank you so much.
Thanks, Dr. Sonu, for that wonderful presentation. In fact, this is one of my first indications. I mean, one of my most important indications for choosing Femto. And even if I can do it free of cost for a patient, I would not hesitate to choose that, especially in one-eyed patients. Mahipal sir, please, take the discussion forward.
So I think we have had a lot of discussion on the intumescent cataract. The OCT, as is seen here, as also the intraop OCT, actually gives you the clefts, the water vacuoles, and the fluidity that is there. What is also very, very important in these particular cases, as was highlighted by Sonu, the biggest difference between anything that you do otherwise is that it is a closed technique, and this is something that the pressure that is exerted once the chamber is open is not there. But as was pointed out earlier by Dr. Ramamurthy, and Sonu has also pointed out, always keep Trypan Blue handy and always use that. I agree with you. I think one of the places where I would push the patient, apart from the polar cataract that we have talked about, is the intumescent cataract or a phacomorphic glaucoma, that one would want them to go in for a femto laser assisted capsulotomy. Anyone else has any comments? Or
yeah, Ram. Comment, my part.
Ram.
Says that actually, I agree with Gaurav and yourself completely, in the sense that it's a great tool as far as intumescent cataracts are concerned. But in these really white cataracts, I actually switch off the fragmentation, because the OCT finds it the problem to locate the posterior capsule, and I really don't see much of a fragmentation happening in these cases. Hard brown nuclear cataracts, laser is light and there's some amount of fragmentation. Here, sometimes I don't make incisions, I just use it for capsular X's and arcuate keratotomies. But still, I feel it's a great tool. And sometimes having the fragmentation on with this is a little more problematic.
I think you are
Mohan Rajan.
Mohan.
Thank you very much. Sorry for the delay, because I was in the SN alumni webinar. But I would say that we have to be a little cautious as far as the intumescent cataracts are concerned, white cataracts are concerned. Always stain this and look for skip areas, and maybe do a rexis just like the way the regular rexis is being done. And also many times the patient also can occur, and the laser penetrates beyond the capsular rexis, beyond the anterior capsule, and you can see that the fragmentation of the nucleus can also occur in white cataracts. I'm not talking about the totally white cataracts, but near white cataracts or near total cataracts, definitely there's some amount of fragmentation definitely takes place. I'll be showing on video on that if you have the time next time.
Definitely, sir. Dr. Sharath, would you like to chip in with your pearls on intumescent cataracts?
Yeah, for intumescent cataracts, I am scared to do the catalyst. I just do the Phaco. The reason is it is not complete. So when the pressure is more, I go for an ordinary thing. So I don't dare do it, but probably after some cases I might be comfortable.
So I think we have to send the clinical applications guide to you, because frankly, Catalyst is amazing. Not only Catalyst, even any femtosecond platform for that matter, because you will enjoy your intumescent cataracts and your worries will go away. There is no other way of doing the rexis better than the femtosecond laser. And I'm sure next time we have a webinar with you, you will concur with what I say. I think we should go on. Yes, Mohan sir.
No, I think we should increase the energy, increase the offset also. These are two modifications you have to do.
Yeah, but I think he is still in the. How many cases have you done? How many cases old are you?
I'm 150.
Okay, good.
I think the primary indication for a laser cataract surgery is capsular rexis.
Yes.
And I think it creates a great capsular rexis, and I would think that I would use it just for the capsular rexis.
I think Dr. Rohit is itching to say something quickly.
Yeah. I think intumescent cataracts is one place where it's highly indicated. Number one, but the rule of the thumb is that don't take it for granted. There are skip areas. Trypan view staining is one of the most important things.
Yes.
I felt that it was not adequately stained, because at times you can, and instead of using, when you take the visco in, you have to be very careful how you are placing the visco so that you make the flap go flat on the lens. If you don't make it go flat on the lens, then it can extend also. So that is another click which should be borne in mind. And capsulorhexis, microcapsulorhexis forceps for that matter, I prefer rather than a cystotome. And I think
lovely pearls, Rohit sir. And I think we should go on to the last talk. Dr. Namrata, you have any comments on this before I go on? Any one quick comment?
I think everything has been said. So
great. So I think we'll take your pearls after this talk. And I have the privilege of inviting. Yes, Maipal sir.
2 talks, not last.
I know that yours is the final word. I am totally aware of that because that's like the final word. No, that's not a talk session and the future of laser correction. So I think I'll invite Dr. Mohan Rajan sir, who's joined us a little late, but nonetheless we are going to make full use of his presence here. And Dr. Mohan sir has been a fantastic surgeon. You know, he's the OPL king of not only India but of all the whole world, because he has won over 50 OPLs. He continues to humor us, and he does fantastic surgeries, and he organizes a wonderful live surgery session every year in Chennai in January, and he's full of wit and humor and lots of excellent pearls for us. I would love to invite Dr. Mohan to please go ahead and give his talk on a very difficult topic, but one indication where femtosecond is very useful.
Okay, thank you very much, Gaurav. Are you able to hear me?
Yeah.
Very much. Please go.
Okay. And also for the wonderful opportunity for the IIRSI, and you're able to see my slides as well, no? My 2 cents as far as the Femto for hard cataracts is concerned, these are my financial interests. As you all know, the keys to the refractive cataract surgery is increase refractive accuracy and decrease the complications like corneal edema, choose the best quality, visual quality IOLs, and exceed the patient expectations. Hard brown cataracts, as you all know, is a very great challenge to the phaco surgeons. Difficult posterior plate attachments, thin posterior capsule, large nucleus, poor or no cortical cushion, increased incidence of corneal edema and postoperative corneal decompensation as well. So you have to combine the technology with the technique. These are the technology, all the missions are available with us. These are the Femto, the Catalyst mission which I'm using. Manual phaco, in my opinion, is like Sachin Tendulkar, and Femto phaco is like Dhoni. It's available in all the formats. Dhoni can play in all the formats, and that is the reason why I compared Dhoni with the Femto phaco with Dhoni as well. And you can see the brown cataract. It's like a piece of granite inside the eye. You can see that it's a very large cataract, large nucleus, as large as thick as about 5 to 6 millimeter, as large as about 8 to 10 millimeters. If you do a manual phaco, you can develop a problem like this corneal edema on day 1, and corneal edema doesn't stop with the corneal edema, which may take about a few weeks to clear or months to clear as well. But you can also have fibrin reaction, which are because of the inflammatory cytokines which are released in the anterior chamber, in the anterior chamber as well, in the anterior segment as well, and also the incidence of cystoid macular edema, which is as high as about 25% in patients with corneal edema. So this is a conventional method which I was doing for supra hard cataracts or hard brown cataract. That is called the quick chop express, a vertical chop. This was the method I was doing prior to the advent of the catalyst with me. And you can see this is the phaco power, which I'm using about 60%, vacuum of about 450 to 600 millimeters on the Stellaris PC mission, duty cycle, pulse, and with a effective phaco time of almost 15 seconds in this particular case. I have to do a trench, and then I'd go bevel down, and you can see the amount of the lateral separation I'm using on this particular. I'm just wanting to show this case just to show you how much effort and this thing I'm taking time to open up the posterior nuclear plate. Every time I open up the posterior nuclear plate, I have to use more phaco power as well. And if I use more phaco power, there's a more chance of corneal edema as well, more heat getting delivered to the corneal endothelium as well. So these are the problems. You can see here, these are the multiple fragments I have to make. I have to literally use my sharp chopper and go all the way down to make this fracture the posterior nuclear plate, which is very, very important in this brown cataracts. Now, look at the hard cataracts. What I'm going to do in catalyst, the vertical spacing about 25, grid space about 250, and you can see the pulse energy anterior and posterior. If the rock hard cataracts, I make the vertical spacing much lesser, that is about 20, and grid space about 200. So I don't do softening of the cataracts as well. You can see this is just to show you the hard cataract and the brown cataract, which I'm going to show you in the next few slides as well. Okay, this is a catalyst mission which I'm using for this hard cataracts. It identifies, you can see the thickness of the cataract on the OCT, how thick it is, and it's quite thick as well, and the pupil is not very big. So the advantage of the catalyst is that I know exactly what is my size of the pupil. I know exactly what is the size of the rhexis I want to. I make it about 5 millimeter, 5.1 or 5.2. Normally the pupil is fully dilated. In a hard cataract, I do it about 5.2 millimeter. Other cases I do about 4.9 or 5 millimeter. But in a hard brown cataract, I do it about 5 or 5.1 or 5.2 millimeter. So this is just to show you the catalyst mission. And only thing is, if you're in a hard brown cataract, sometimes it takes a little more than 60-65 seconds. I make sure that it is not very long, more than maybe 1 or 1.5 minutes or 90 seconds or 1 minute or something like that. So you can see this, how the rhexis is really perfect in these patients, and how the octants are there. Already the segments are there, and more importantly, you can see the gas bubbles are coming out. I just do a small little trench and straight away go in and do the chopping. I do the bevel down. It doesn't matter whether you do bevel down, bevel sideways, or bevel up, doesn't matter at all. But you can see that I'm using very, very little lateral rectal forces, and because of that, I'm able to, the very fact that the gas bubbles are coming from the posterior plate, it means that the cut has gone all the way down into the posterior nuclear plate. And once I open up the posterior nuclear plate, then it's a very easy matter. It's completely a child's play for that, because as I told you, the combination. You can see the EPT in this particular case is only 5.5 seconds in this particular case, because of the hard brown cataract, because of the catalyst I'm using. Another case I'm going to show you, just to show you that the capsular rhexis is done. Then straight away I do a small trench there. You don't have to do a trench at all. You can see that the lateral separation, that is very, very important. The lateral separation is again very important. Again, just to show you that this fragmentation is going all the way down in hard cataracts. I'm not using a very sharp chopper. I'm just using a Sinskey hook in this particular case to open up. You can see that I'm just using a Sinskey hook to open up the posterior nuclear plate, which means that the posterior nuclear plate is already been fractured by means of the catalyst, Phaco, the Femto Phaco mission, and the Femto Phaco, the catalyst mission, and that is a huge advantage. You can see here, I'm going all the way down. I'm just separating that nucleus very, very gently, and you can see that opening it out very nicely in a patient with a grade 3, grade 4 cataract as well. Again, you can see here, I do the incisions. Most of the cases, I do the incisions. I prefer that at least the main incision I do, because I feel that incisions are a very, very important aspect as far as hard cataracts is concerned, because I get the typical triplanar incision, which is very, very good incision for me to handle these hard cataracts as well. So very gentle hydrodissection, because the gas is already there, and in the posterior nuclear plate, in the posterior compartment as well. And I go ahead, and you can see here I'm doing I use a 15-degree tip on the Stellaris mission. I use the Signature Pro or the Stellaris, but I prefer the Stellaris, the Venturi system, for this particular thing. You can see here how the opening up of the posterior nuclear plate is again very, very important, because the gas bubbles are coming out from the posterior nuclear, from the posterior compartment. That is an indication that the posterior nuclear plate is completely fractured in this. And you need what you need to do is just to separate this, and because of this, you require very, very less phaco energy as well. And this is the way you go it. And this is again another patient with the brown cataract, grade 5, grade 6. The grade 5, grade 6, I have slightly different parameters for this particular patient. And you can see here that the same method of separating all the way down very, very easily. Of course, your left hand has to work better than the right hand in all these vertical chopping cases. Again, to show you, to take the difficulty to a slightly higher level, I'm doing the Femto brown black cataract. This is done on the live surgery last year in the surgical strikes. You can see here I'm using a Signature Pro machine. Again, you can see that very simply it opens up. Very simply it opens up. Very easily it opens up. That itself shows it's a very, very brown cataract. That itself shows that the femto cataract does the fragmentation, which makes life easy. I do the octants in these cases. I don't do the softening, and you can see the whole thing just pops up, and the cornea is very, very crystal clear. Again, a patient with a hard cataract with a cornea gattata of a count of only about 1,000 odd. You can see here again, I'm doing this particular patient. I'm using an a Centurion machine in this particular case. Doesn't matter whatever machine you're comfortable with. Just do the Rexis, and then you can go ahead with the Phaco machine. Because of the amount of Phaco energy, which is very, very less, and already because the fragmentation is done already by the catalyst machine, it makes very, very life easy for you. And because of that, the Phaco energy, the nucleus emulsification also becomes easy. You can see the femto 2 hours after the patient with the cornea gattata, severe cornea gattata, and you can see that 1 day after the surgery, how the cornea is crystal clear. So this is the take-home message I want to give you all. The hard cataracts, hard brown cataracts is one of the major indications for femto for me nowadays, because I want a pristine, clear cornea and a pristine wound as well on day one, which is very, very important for me to prevent all other complications for the patient. Again, just to show you how to the white cataract, I was talking about it in the previous session as well, and you can see here how the white cataract. So don't underestimate this catalyst. If the OCT recognizes the lens, then you can go ahead with the fragmentation as well. I always use liberal amount of trypan blue and look for the skip areas in the capsular rexis. And in this particular patient, this patient required a toric lens. So this is the skip area which you have to be very, very cautious. You can see here, once I'm chopping it, the chop has gone all the way down. You can see the fragmentation has gone all the way down. I'm not using any force on the chopper as well. You can see the fragmentation has occurred in the nucleus, despite the fact that it is a white cataract. You can penetrate the white cataract very nicely as well in some of the cataracts. So white cataracts, hard brown cataracts, posterior polar cataracts, subluxated cataracts, Fuchs endothelial dystrophy, I think this is a perfect indication for catalysts. Reduce surgical time, reduce effective phaco time, more precision, clearer corneas day one, reduce complications, safety, precision, bladeless, and all these are important factors. Thank you very much for the wonderful opportunity.
Thanks a lot, Dr. Mohan sir. And I think we have the most important talk of the day now, because that's what is going to tell us what is the future of surgery. And I'm going to invite Dr. Maipal, but I would also like to tell each of our speakers to keep themselves ready, because at the end of this talk, we'll have a small discussion, and I will be taking one pearl from each of you for the benefit of the audience from today's webinar. So I'll invite now Dr. Maipal sir. He actually needs no introduction. He's the king of Indian ophthalmology. He's the president of IIRSI. He's the chairman scientific committee of Intraocular Implant and Refractive Society of India. He's a dear friend. He's a guide. He has, pulled me through the years and guided me through of, ophthalmology and how we've developed our practice. He continues to be a guide to so many of us. So Dr. Maipal sir, where is femtosecond technology headed for cataract surgery, and what do you see the future? I know you are great at predicting the future of technologies.
Thank you very much, Gaurav. I'll be talking about the advantages, the new advances that are going to happen as regards the femto technology. So as has been said, life can only be understood backwards, but it must be lived forward. So there is a lot to learn from what we have already learned from femto laser assisted cataract surgery, but we need to always keep on taking it forward. Now, when one of the most important new things that is coming on to the Catalyst operating system, which we are using, is the 5.0. It is the 6.0 that is coming on. Is that astigmatism is still an unmet need. And when you look at the market scope study, which was done in 2019, what it shows is that only 33% of the patients, they are getting the astigmatism when it is being corrected, and in 49% of the cases, no surgical astigmatism correction was attempted by the surgeons. Now, obviously, there is this unmet need, whether it is going to be fulfilled by the Toric IOL or in cases where the astigmatism is less, we are going to have it fulfilled by the LRIs that we can get or the AKs that we can get with the system. Now, the new system, which is the Catalyst operating system, which is the 6.0, this is with the advanced astigmatism management, which has been introduced in Europe and also in limited use in US. And we are expecting to have this in the year 2021. Now, there are three important things that this system does as regards the astigmatism. The first thing is that it simplifies the astigmatism management workflow. So what we were talking about earlier is that system is pretty intuitive and it works very well, where you don't really have to spend much time on the Catalyst system. And when you are looking at the astigmatism, that is the thing that needed some investment. There is the speed which is increasing for the operational efficiency. What is most important is that it is making the entire system much more accurate to deliver the superior results. Now, let us see that how it works. The first important thing that is there is that it is a direct entry of the preoperative data. That means it minimizes manual transcription errors between devices. So you will have to use a Cassini. It's like a Pentacam that is there. We don't, a lot of us don't have it. The Cassini topographer will have to be used, which we also use the posterior surface. There is going to be a built-in nomogram which is going to calculate the arcuate incision parameters. That means that you don't have to apply whether you want to do the Donner field or whatever you want to do. And this is automatically entered into the treatment planning screen. Now, the other important thing is that there are radial laser alignment marks, and this is designed to reduce reliance on intraoperative aberrometry for Toric IOL alignments in the OR. So there are two parts to it. One is when you are looking at the corneal arcuate keratotomies, and the second is when you are looking at the IOL placement, that is a Toric IOL. So this has systems which are going to help you for both of these. Now, the first important thing, that is the direct entry of the preoperative data. This is going to minimize the data entry verification. So it's going to increase the speed. There is an onboard nomogram. So this is therefore no time that we have to spend on calculating as to what it has to be. And it is also going to import the iris registration. So you have an iris registration of a person who is sitting up, and when the patient lies down, it is going to have the torsion, cyclotorsion marked. So it is going to eliminate the need to manually mark the eye and align the patient interface. So this is something which is very, very important. So as you can see here, this is, it is coming itself that this is where the incision, arcuate incisions would be. This is the primary axis which is there. So this is basically the nomogram that you have, which is being used is Donner field nomogram, and this is preset there. Also, you have the possibility of whether you want the anterior penetrating type or you just want the intrastromal. So this is also going to be available to you as to what you want and where you want the arcuates, which the machine will let you know. Now, when you're looking at the accuracy, now accuracy for any astigmatic keratotomy or for a Toric IOL are something which is very, very important. Now, if you look at the study which was by Wizard and all, which was in 2011 as regards manual marking. So if you have the marking, which are two markings that you have to do, one is the reference axis marking, the second is the alignment axis marking, and the third would be the final IOL alignment which is there. So if there are errors, then they could stack up. Now, what is very, very important is that if you have for the reference marking, the average error was about 2.4 plus minus 0.8 degrees, and it could vary up to 10 degrees, which is there. Now, in this system, there is going to be an automated cyclotorsion compensation. That means that the accuracy will be within 0.8 degrees, which is 3 times better than the manual marking and would eliminate the surgeon dependence on manual compensation. So this is something which is very, very important. If you have, as I told you, in the manual marking, you have an error of 2.4. When you have the alignment axis marking, it could again have an error of 3.3. So if you compound this, the error stack up could go up to 4 degrees. And if there is the IOL misalignment, then this could actually go up to 5 degrees. So that is the problem which is there. Now let us just compare it to what this Catalyst 60 system, the 60 system is going to give us. You can see that this drops down from 2.4 to 0.8. The alignment error goes down to 0.58 degrees. And when you look at the IOL alignment, this is the axis alignment and this is the IOL final alignment, this goes down to 1. So therefore, you have almost a 3x reduction in the total error stack up that is there. So what is also seen in a recent study with the Catalyst is that it actually very accurately calculates the cyclotorsion after docking. Now, the next important thing that the astigmatism management program is going to give you, apart from what you have for the arcuate, is that it is going to give you laser alignment marks. So you have a system where you can get the marks on the capsule, but you can, in this particular case, you can have alignment marks onto the cornea. So you have the Cassini, which is going to find out where you have to place your IOL. So you have the system, you put it in the Cassini, and with the precision and accuracy of the system software, you can find the target. And you will be able to hit the target as regards the corneal alignment. So this is something very, very important, that you find the target with the Cassini, you can hit the target with making these impressions onto the cornea, and you can grip the target by using a toric intraocular lens. Now, what is also very, very important, apart from the 60 which is doing, I think what the future of Femto would be that we should be able to use the laser again for doing a primary posterior capsular access. This 60 does not have this, but this is a wish list that I am saying that this is what the future of the flags would be, that you could be able to redock and you can get a clean punch to do a primary posterior capsular access. And that would be especially important for the pediatric population, where you don't have to do a more difficult surgical capsular access. Now, the other important thing that is also happening, again, not with the 60, is what is known as the refractive index shaping or the laser-induced refractive index change, LIRIC. So what this is the first generation of refractive surgery patients are reaching the cataract surgery age as is happening, so they don't want any refractive surprises. So if you are able to reshape the cornea at the corneal level, you could possibly change the cornea in the postoperative period. And the laser-induced refractive...
Not able to hear. I think his network is a little weak. Maipal sir, we can't hear you. Can you hear us? I think we lost him for a moment. Let's see.
Yeah.
His video is there, but the audio is not there.
It's paused.
I think it'll come back. Yeah, it's still paused. So we've lost him for a moment. And let's hope that he can join back in a few seconds. But you know what I'm realizing is that we are getting a little bit of a second class citizen treatment from J&J here, that all these things are not coming to us first, and they're coming to the US and Europe first, and India is actually one of their big markets. I think Maipal sir has lost connection, so I can see that we should have had these enhancements.
Is Dr. Soonpik?
Yeah.
So Dr. Maipal sir, you're back. We lost you in that last slide. Can you finish off with that, what you were going to say?
Okay, fine. Sorry. So, is everything visible?
Yes, now it is, sir.
Slide number 13, yes.
Yeah.
Okay, so basically in LIRIC, what we are talking about is that you can actually use the femto laser at a point on the cornea or in the IOL, but the wavelength is going to be different. What it does is that it changes the collagen within the cornea, or it can put Fresnel shaped prisms onto the IOL, and therefore it can be used to do refractive correction after the surgical procedure has been done. Now, the other important thing which we would suggest the Catalyst, I think this is a good thing which is there in Lensex, which is the live streaming from the OR to the steep axis that you can see. But the important thing, as was talked about by Dr. Chi, is the integrated swing flow camera. Now, this would identify the morphology of the core, and it would optimize the energy, so that if you have this, it will categorize as per Professor Dick into the category 1, 2, 3, 4, 5 as to the density of the nucleus, and you can actually see the posterior nucleus even in the dense cataracts, and based upon that it will create a pattern for optimizing the energy and the cuts which are there for these type of cataracts. So I think optimization as regards identifying the nucleus and to go on to swept source OCT is something that would be required. Now, the other important thing which is also available sometimes is that if you want to do an LRI or a microcorneal incision to do a top-up, should be available with the femto laser. That means that you could use it as a refractive tool. Instead of doing an excimer laser for correcting residual refractive error, if there is a small amount of astigmatism that is there, you could possibly use this, go back again and use this to make the microcorneal incisions to fine-tune the refractive deficits that are there. So I think these are a couple of the advances which are going to be available to us. Some of them which are going to be available in the 6.0, but some of them which I put it as our wish list as to what the catalyst system should be improved upon to give us better outcomes in the future. And this is the other thing that I was talking about. This is the incision this is the what you have on the capsulotomy. You have these knuckle shaped, which is available in the LensAR, but I don't mind if we have small points onto the cornea, which can be seen even post-operatively to see whether the lens has remained in position or not. So that is whether you do it on the capsule or whether you do it on the cornea. I think both will be great. And I think that is going to be a great outcome as regards the astigmatism correction that is there. So summarizing the horizon, I think there is going to be room for improvement in logistics, which is something very, very important, that the devices should be mobile. You should be able to transfer it from one institution to another. But the most important thing is to make it much more affordable, to have a reduction in the click fee that is there. Primary posterior laser capsulotomy, we should also be allowed to have refractive enhancements and treatment of the implanted intraocular lens. Lyric is going to be one thing, but I think the 6.0 catalyst system is something that we would wish to lay our hands, wherein we can get better outcomes as regards the astigmatic keratotomy, as also the placement of the toric intraocular lens. Thank you very much for your kind attention.
Thanks, Maipal sir. I hope we get that device free of cost from J&J for doing the cyclotorsion control, and let's with you as the president of IIRSI, I'm sure we will.
No, I think it also entails the purchase of a Cassini. That's the main.
That's what I'm saying. I hope we get the Cassini free of cost, at least for the existing users, and not, maybe not for the future users. All the same, I think that was a fantastic talk, Maipal sir, because it gave us insight into what is likely to come up and what we really need. I mean, the wish list. And I think we've had a fantastic webinar. I'm going to take this opportunity to ask all of our speakers who still remain with us and the panelists to chip in with their one take-home message for the audience who may not be doing femto-assisted cataract surgery. Yes, Ramamurthy sir, please.
Yeah, no, it's a great talk, Maipal, but this question to Sunchi Pek, we are most often optimizing our settings as far as Phaco is concerned. But in your presentation, I saw that, even for femto, you are doing it constantly. Can you just very briefly offer some guidelines? Because I don't know about other panelists. I usually use settings which are given to me by the factory, and there's very little that I do except for adjusting the offsets.
That was the whole idea of calling him for this talk, Ramamurthy sir. Thanks, Dr. Chi. Please tell us.
Well, I think, first of all, I would recommend that you use just a single pass for the very, very hard cataracts. Okay, that's for nucleotomy. I mean, I hardly ever adjust that at all. So whether I do a soft cataract or a hard cataract, actually, I just put in the maximum energy and a single pass. So that will actually save time. It will also produce less gas. So that will actually make surgery safer. For the capsulotomy, really, I think I do adjust the energy, and I also adjust the what is the other thing I adjust? I adjust the size of the capsulotomy. Yeah. The offset, I don't really touch that at all. I might adjust that actually looking at the subluxated lenses that probably during the treatment are not so stable because the zonal lysis is pretty severe. So the infinite during the femto, it may actually move a bit. And I think that's why sometimes I don't get it complete, even though there's no obstruction. So I might increase the offset for that. But otherwise, I just adjust the size. So for the young patients, I tend to make it smaller because it tends to expand because it's very elastic. And we know that from Bahadik's work, actually. So any patient who's below 50, I would do something like 4.8. And for the Intumescent ones, because the capsule is also stretched, I also tend to make it a little smaller. Also for subluxated cataracts, I tend to make it smaller because it's much easier to put on the hooks than if you have a large capsulotomy, because the angulation becomes very vertical for the hooks to provide that support, and you can actually slip off, especially in patients who've got a deep anterior chamber like the high myopes that we deal with in Singapore. So that's what I would do for the capsulotomy size. If you have a very fibrotic capsule, all right, and these are those that you would actually want to look at preoperatively and take notes so that your technician can straight away screening through your notes actually prepare for the laser by increasing the capsulotomy energy so they can cut through fibrotic capsules. In terms of posterior polar, as I said, I generally do not increase the offset, but actually when I reviewed my videos again very recently, I found that in those cases that actually when I had the gas bubble through it, actually looking at the preoperative OCT, probably you can tell that these patients actually might have had that break like what we were discussing earlier. And for these patients, then I would actually increase the offset. Otherwise, I generally do not for cases that I don't think I have got a breakthrough there already. Other than that, I don't think I really adjust any other settings. Yeah, but of course, for capsulotomy, whether you do a scan capsule or not, if you think it's zonalized, then I would actually do a scan capsulotomy. Otherwise, for my standard cases, I don't, because I find that that is not 100% accurate, and sometimes I've been played out with the descended capsulotomy.
If you're planning to do a primary, a posterior capsular, anterior capture of the IOL, like for example, if you have a break in a posterior polar cataract, what size do you aim for your capsular excess? Like, would you keep it at 5? Like, if you're planning that.
At 5.
I had a problem with one of my patients for the first time in so many hundreds of cases that I was doing a posterior polar and we did everything fine, but that patient had a PCR at the end of the surgery, and then I put in a 3-piece in the sulcus. But for some reason, even with a 5 mm rexis, it would just not capture. I was amazed because it's never happened to me before. But I just thought I'll put that across, and if anybody has an answer to that, I would love to hear.
As I said, it might be the age of my patient. Young patient. So it's elastic.
It was a young patient, yes.
Yes, so it's stretched. That's why I always downsize when the patient is below 50.
Yeah. Right. So I think
always retracts. Usually when I do a Phaco, my rexis size is 5.5 millimeters. When I do a LRCS, it's 4.9 or 5 millimeters. Because invariably it tends to retract over time. Even on the table, you finally get a slightly larger rexis than what you aimed at.
For that matter, any rexis can enlarge. Even when the manual rexis can also enlarge during it. See, when a manual rexis, when you make it 5, at the end of the surgery, it may be 5.2.
I think for the benefit of the audience, does anybody of us feel that the rexis in Femto is not as strong as a manual or a Zepto rexis?
No.
Okay.
You do? Because I don't see broken rexis with Femto more than I see with my manual cases. But Dr. Chi, do you see that?
I think we published this in a study recently in the JCRS when we did it in the lab, and that was done in the SNEC. Yeah, we actually.
No, are you trying to compare it to the Zepto or to a manual rexis?
To manual. It was done
manual?
In comparison to a capsule laser with manual.
And is there a particular group of patients where you found this, or was it like anybody?
It was in cadaveric human eyes. So it was like 50% of the strength of a manual.
The idea
but in clinical settings, do you see a difference in the number of rexis breaks that you see between the two groups?
I think that I've seen it more in the Victors than in the Catalyst. The Catalyst, sometimes even when you've had to actually complete the rexis, by just pulling radially rather than doing a circumferential tear, it's, still reasonably strong. Yeah.
Yeah, so for me, for the Lensex and Catalyst, both have been excellent as far as the strength of the rexis is concerned. So I think, Maipal sir, should I ask each of us for take-home poll? And I'm going to start with Gitansha, who's our youngest, star participant today. She's been patiently with us through this, and I would like to ask Gitancha for one quick take-home message, and then we'll go on to everybody. What you felt for the audience, for the audience who may or may not be doing femto-assisted cataract surgery.
So I just like to say that in posterior polar cataracts, the use of a preoperative anterior segment imaging is important. If you feel that there's a breach in the posterior capsule, the epinuclear sheet should be thicker than what it is by increasing the posterior offset, because it will help to provide a cushion for both the mechanical and the hydraulic forces that are there during the phacoemulsification process.
Wonderful, Gitancha. Thank you so much. And now I'm going to ask the person who has started doing femto most recently, and that's Dr. Sharad Babu, because I'm sure he found a few take-home messages from here. And what would you give as a take-home message, sir?
Yeah, the Catalyst is a really good tool for me, especially while changing from to the Catalyst segment. What I found was it was really good for my hard cataract, and also for less than 1 diopter, I've been using this machine for the reduce the astigmatism. And after seeing you with all this, I think I need to really come up and then use it more often in all the type of cataracts.
I think experience, nothing better than experience. The more the cases that you end up doing, you'll probably learn what we have learned over the years. But thank you so much for those tips. And now I'll ask Kumar, who we've allowed to fall off to sleep maybe by not troubling him enough. Kumar.
I want to make a comment, and I want to add one wish list to my past list. So one thing is the highest I've done is softening and octane in a very hard cataract, and the femto time was 2 minutes, as mentioned by Professor Chi, that sometimes it goes to 4 minutes. Now what I've noticed then is that if there's a slight eye movement, the shots that are repeating itself are not falling on the same spot. So I would add a wish list that this machine should have an active eye tracker like excimer lasers, and actually that ensures that the spot that is falling the next is actually falling at the same spot, and you really can accurately control the fall of the femto laser on its spot where it's supposed to be. So my thought process is that if you can have an active eye tracker with and swap source OCT is what will make this technology much more accurate, is my thought process. So Mahipal, and this is just a discussion. And take-home message would be like, as discussed, brilliant for hypermature cataracts, posterior polar, subluxation, no doubt. And according to my clinical experience, it holds on very well because we are able to put capsular hooks, we are able to put iris hooks, and these capsulotomies do not tear. So in clinical experience, what I'm seeing is that they are as strong as manual rexes. May not be in the lab, but clinically I'm seeing that they hold on very well.
Thanks, Kumar. I'm going to ask Dr. Rohit, who has, not commented as much. And, Rohit sir, so what is your comment on, how people who are still not doing femto, what would be your take-home message for those who are not doing femto, and, you would want to tell them something?
Well, with my experience, what we have done is I have been able to identify the potential advantages of flax. And we are offering this not only to the premium IOLs, to all IOLs with an add-on cost. So which has opened a Pandora of patients who are opting for flax by making it affordable to all. So be it weak zonopathy, intermittent cataract, black cataracts, PPC, normal cataracts. So this has opened, it's not only patients who are using premium IOLs, they are going in for flax. Even with those who are using biotech, aspheric, be the spheric, the very word as Dr. Mahipal and Dr. Grewal, who have been the pioneer in spreading the message of, this robotic cataract, as they call it. People want it, and let it be within the scope of everybody.
Wonderful message, Rohit sir, because I think that really makes, and I think at this point we should request J&J to bring down the cost of the technology and the consumables cost, so that it can reach out to more and more people. Right now I think it's limited to just the 100 or 200 people who still use it, and I think the potential is amazing. Just like Phaco machines, if this could be made more affordable and the click fee could be brought down. Dr. Namrata, you come from an academic institution, and you have the benefit of seeing both sides of the story. And what is your take-home message for femtosecond technology? And there are a lot of people who feel that femtosecond is not the way to go, and they are sure that SICS and Phaco is what is, and there's no point even looking at femtosecond lasers. What is your take on this and from the academic point of view?
I think there's a huge potential for doing cases, especially in complex scenarios like subluxated cataract, posterior polar, and hard cataracts, white cataracts. I also would agree with Dr. Rohit Om Prakash that even for us, we have also subsidized the rates quite a bit. So not only for premium IOLs, but we are also doing for other cases which are not premium IOLs. We are just using the technology to get past the hurdles or to do the difficult cases in a more in a manner which is becomes more easy. And I was very impressed by Dr. Mahipal's talk. I'm sure that is the way to go. That is the future. We do have CASIA, but we don't have a catalyst. So I think for us, it is going to be the other way around. We are going to be, buying a more expensive tool rather than CASIA, which is less expensive.
They should be gifting it to you.
Yeah. So I don't think that is going to be future, and that is something to look forward to.
Thanks, Dr. Namrata. Now I'm going to ask Dr. Mohan Rajan sir, because he joined us very late towards the end of the webinar, and he always has great pearls and take-home messages. So please tell us, what is your take-home message for those of us who still don't believe in the femtosecond platform? That what is your take-home message for them?
Now, femtosecond, in my opinion, is very good for all types of cases, especially for complex cases. As I told in my presentation, I think it's a very, very beautiful. Don't underestimate the potential of catalyst. It's really fantastic. It is. And the most important factor, in my opinion, as Rohit rightly said, is the cost. If the J&J or even the Alcon, if they're able to bring down the cost, then this femtosecond will penetrate the market like anything. Because everybody knows there is an advantage of the femto over the conventional phaco. But there's a cost factor which is preventing them from buying it. Especially in the post-COVID era, it is going to be more difficult. So I think the companies have to make a consensual decision to bring the cost down so that it can penetrate the market, because there are huge advantages with the femto. Whether you take it as a regular cataract or a complex cataract scenario, or a hard cataract or posterior polar cataract, or even for a moderate pupil, I think it's a great tool which is there in your hand, which can give better outcomes to the patient.
Wonderful. So now next I come to Dr. Ramamurthy sir, because he's always full of wisdom and wise words for take-home messages. Dr. Ramamurthy sir.
Frankly, I have no other choice but to echo what was already said, because I believe that laser cataract surgery is at a stage what Phaco was in the early 2000s. It has come to stay. We have to build upon it. And every patient deserves it. And if at all there is a barrier to it, it's only the cost. I think the companies as well as the ophthalmic fraternity owe it to themselves and to their patients to manage the costs and offer this wonderful technology to everyone. It's not just the difficult cataracts. When I started with this, I thought it's essentially for grade 1, grade 2 cataracts. Now I believe it's for the more difficult patients. So I think to get great results, whether it's difficult cataracts or whether it's ordinary cataracts aiming at emmetropic outcomes, this would be a great tool. And I think we have to just work together to ensure that we are able to reach it to each and every one.
Thanks a lot, Ramamurthy sir. And before I ask Dr. Mahipal sir, I'm going to ask Dr. Cheet for a final word, and then I'm going to ask Dr. Mahipal to sum it up for us here.
I think this has been a great webinar, and I'm thankful to be here and having a part in it. And we have all talked about how good it is for complex cataracts, but as we know, most of the time we are doing it, most of the time our work is on standard cataracts. And I think it's especially good for soft cataracts. I mean, I've seen my juniors actually mess up cases that are soft, and really we have no excuse not to give these patients with soft cataracts who start out with vision that is not really that bad. We cannot give them worse vision because we have had a complication. And I think that it helps us, those of us who are good surgeons actually get perfect outcomes. Because even if we are good surgeons, we can just get good results. It may not be good enough. We want to have that perfect outcome. And I think it gives me no greater pleasure than seeing a capsulotomy that's perfectly centered, perfectly round, well-sized, and with the IOL nicely having the overlapping edge, and it's just a pleasure to look at. And so, very often I have people asking me, why do I like to do femto when I can do a nice rexis? And I think that, I can do a nice rexis, but I cannot consistently do it. And this gives me just, that edge over a person who's just doing it manually. Maybe only Akahoshi can compete with a femtosecond laser, as I've seen him get exactly the correct size and shape all the time within seconds. So that's why I really think, for those of us who have not gone to it, I think we have not really tasted, the extreme pleasure of doing cataracts.
Thanks, Dr. Chi. And you very rightly said that soft cataracts, I also feel that it's a great tool. What percentage of your practice is femto? Before I move on to Dr. Mahipal sir for the final word.
For private patients, it's 100%. I mean, they just ask me, what do you like? And I said, well, I like femto, and that. Then they'll say, okay, whatever works best in your hands, because we want the best outcomes.
Wonderful, thanks. And now, for the final word, as always, I invite Dr. Mahipal Sachdev sir to tell us that what his take-home message is for the audience, and he will sum it up before I thank all the office bearers and everyone.
Well, thank you very much, Gaurav. I think been a great webinar, which has brought about the advantages of the femto laser, especially the Catalyst platform. To sum up, what I will say is that today, as Dr. Ramamurthy said, everything has an inflection point, and I feel that femto laser today is at its inflection point where the number of laser users has increased. The penetration of the percentage of the procedure that a surgeon is doing is going up. The same center growth is about 25 to 30%. But for the COVID, I think it would have taken maybe 12 to 18 months more for it to become more of a household name. And as what Dr. Chi said, what is very, very important is that it is something which is a step towards perfection and repeatability in everybody's hand. So whether it is a young surgeon, a new surgeon, or whether it is somebody who is more experienced, I think in everybody's hand, it gives you repeatable results as you require. So that is something very, very important. The complex cases is the icing on the cake where you can actually use it for these different maneuvers. Now, what is going to be most important is that we should be able to have the insurance company pay for it. As long as it is out-of-pocket payment, there is going to be some problem. And just as a piece of good news, it's only about 2-3 weeks ago that the Haryana government has allowed the payment of reimbursement for femto cataract for their, like the CGHS, you have the Haryana government medical scheme. So I think that's the first place, the first entry point that we have got, where femto laser is being reimbursed by a government agency. So once we have that, I think the number of procedures will significantly go higher. And over the years, I have seen in my own practice, the penetration of the entire procedure increasing. I think Rohit Om Prakash was among the first to put it there. And then at that particular time, we fell into, I would say, not a trap or whatever it is, we fell into a company-based price point, which was 50,000 rupees. The delta was much higher than the delta that was acceptable by the population. So there has to be a sweet spot. And I think that sweet spot that we have found is anywhere between 30 to 40,000 rupees, or maybe in RP center, it's 25, 30, 27,000. So I think that's the sweet spot where the delta is not higher than the original cost of the cataract surgery. So I think if the economics are slightly, whatever discount I got from the patient interface price on the femto from Catalyst versus Lensex, I passed it on in the penetration of the femto laser procedures that is there. It's an excellent procedure, gives you excellent outcomes. And I think as a default in our center, we offer femto laser to all our patients, and they are over the last couple of months lapping it up as a procedure of choice, while people come from outside Delhi just asking for the femto laser procedure. And I think it is high time that all of the naysayers would fall in line and accept that this is a procedure that is going to stay and it is not going to dissipate.
Excellent words, Dr. Mahipal sir. And Kumar, you want to say something?
Your take-home message?
My take-home message, I think my take-home message is that I'm thankful to all of you, for really coming out here and staying this late for so long. One of the longest webinars that I have done. And still everybody's interest is there, and we have a big audience, still with us. But I think for me, as with some of the others on this platform today, that switching from one platform to the other, and we're making it more affordable for the patients and easy for the surgeon, made all the difference. We have very good numbers now. In COVID times, we have seen bigger numbers than the conversion has been much higher in COVID times because patients are more cautious about what they are getting, even though the total numbers of cataracts have gone down drastically, but we are doing more femtos as conversion. So I'm fully convinced that femtosecond technology is great for our patients, great for the surgeon and everybody else. And I'm really grateful to all of you for, making this webinar a big success, to Dr. Mahipal sir, Dr. Amar, who is was not able to join today, the secretary of the IIRSI, also to Dr. Dhami, who is the president of the IIRSI. So to all of you and J&J for making this possible. And I think till we meet again, thank you so much for being here today, and all the best. Please go and have your dinners, and apologize to the families on my behalf. Thank you so much.
Thank you.
Thank you.
Thank you, everyone. Bye. Good night.